Welcome, everybody. I'm Howard Chansky. I'm the chair of the Department of Orthopedic Surgery and Sports Medicine at the University of Washington. And this is a great tradition that we have every year to honor our graduating residents. And this is a wonderful class. And we are looking forward to hearing your talks today and meeting your families tonight. And we are really honored to have Dr. Joaquin Sanchez-Sotelo from the Mayo Clinic as our visiting professor for resident graduation and resident research day. I can't tell you how much enthusiasm there was amongst the attendings when they heard that he had actually accepted our offer. We had a wonderful time last night with the R4s and Dr. Sanchez-Sotelo and the shoulder and elbow team. And from here on out this morning, I'm going to have Dr. Freddie Yang, who's one of our R4s, be our MC. And as you all know, Dr. Yang will be going to the Rossman Clinic when he graduates next year for an Arthroplasty fellowship.
All right, good morning, everyone. I have the privilege of introducing our distinguished guest, Dr. Joaquin Sanchez-Sotelo. Dr. Sanchez-Sotelo is a world-renowned orthopedic surgeon specializing in shoulder and elbow surgery. He's visiting us from the Mayo Clinic, where he's the chief of the shoulder and elbow service. Alongside his busy clinical practice, he's a dedicated researcher and teacher. He's won many awards for his dedication to the teaching of residents and fellows. He also has over 400 peer-reviewed publications, many of which have garnered international and national prizes. He has and continues to propel the field of shoulder and elbow surgery forward. He's currently the president of the ASCS, the Society of American Shoulder and Elbow Surgeon. So please help me in welcoming Dr. Joaquin Sanchez-Sotelo to Resident Research Land.
Good morning, everyone. Thank you very much for such a nice welcome, so warm, I think all these accolades and introductions are under-deserved, but I really am humbled and honored to be here. These type of activities I enjoy the most because not only get to be with legends like Dr. Madsen, I get to know the new, breed of residents coming out of different programs. So congratulations to all of you guys. You have a very, very bright future. So before we begin, I'd like to start with my disclosures because, of course, in a talk about reversal arthroplasty, the implants that you may see on the X-rays or CT scans are made by a Stryker, and I have a contracting agreement through Mayo Clinic in designing the implant. So what I'm going to tell you may be biased by my implant involvement with the Stryker Corporation. And I want to say a big thank you, when Jason contacted me and said, hey, can you please come to visit us as a graduate professor? Like, oh my God, I'll be there like instantly. It's such an honor. Thank you, Jason, very much. And of course, being with Dr. Madsen, who I never trained with you, but I have learned so much of you. We're talking yesterday night when he gave me a copy of his beautiful book. And I was telling him that more and more I realize, and this has to do a lot with the talk we're doing today, that what he coined years ago, which the surgeon is the method, applies so much to reverse. Because even though we have a lot of science behind it, there is an element of art that I think Jason and Dr. Madsen and others probably master here at UW, but that's actually difficult to master at the beginning of your practice. So we'll talk about the origins of arthroplasty. I love history, and I think it's important to know where we're coming from. We'll talk very briefly about some basic principles. What's the science behind it? Why is it that this is still an art? And then we'll close with a few final thoughts. So talking about me a little bit before we start with the topic, I was born in Europe, which is important because when I finished my fellowship at Mayo and I went to Europe, reverse was already on the market. So I was able to do reverses before coming back to Mayo to work. My father had to be an orthopedic surgeon as well. He did hip and knee and trauma mostly. And like many other children in Spain, we thought we were going to be soccer players. So this is my brother and I, who were little. But playing for Real Madrid didn't really pan out for me. So I had to go into a different career pathway. And I became a resident in Hospital La Paz. This was my chairman at the time, Professor Munera, who was an incredible scientist. And I was talking to the faculty and residents yesterday, and in my home hospital in Madrid, we did get very good training on spine and hip and knee and fractures, but not so much on upper extremities. So I went to visit Mayo Clinic, where, as you know, there is snow on the ground about 6 to 7 months every year. And somehow I ended up doing a fellowship there. And Mayo is an interesting place. It's in a very small town, Rochester, Minnesota, where this gentleman in the center basically settled his practice there because he was part of the Army recruitment efforts and had two children that actually went to Europe to be trained and then came back to the institution. And history says that there was this tornado that happened and basically blew through Rochester. Back then there was no hospital, so the doctors were going into their vehicles to different houses, and they had so many people injured that they had to team up with the nuns and basically create a hospital that grew over time. So I think if the Mayo brothers were able to be awake and alive today and realize that from that little tornado event and creating that link with the nuns and the practice, this center developed, and became such a busy institution where we see many patients every day from all over the world, multiple procedures, and we have the ability to use a number of ancillary services like diagnostic procedures or MRI images, and we're lucky to have access to all these resources and a very good communication. But what I like the most is that our institution remains true to its values, where the patient always comes first and is actually led by a physician. I think those two elements really explain why Mayo continues to be somewhat successful. The logo of Mayo Clinic has three shields. The one in the center is about 20% larger, and that represents a clinical practice, because the most important for us is the patients, but it's supported by education and research. And the key is that if you have a high volume destination surgical practice, where you do a lot of shoulders or hips or knees or spine, you encounter the failures. And that's what will prompt you to innovate. If you do 2 or 3 cases, not so much. But if you do hundreds, then you start to have your own dislocations, fractures, infections. It's like, why is this happening to my patients? Then you have to come up with a new idea, prove it's better. That's why research is important. And only then you kind of earn the ability to teach the world, and that will bring you more patients. So this vicious cycle has been very successful for us. And in terms of arthroplasty, we really honor our first chairman, Dr. Mark Coventry, who was very influential, respected, but more importantly, he had a vision of having a registry of implants. The very first patient that he did was already in the registry. So in 1969, he did the first FDA-approved channel hip arthroplasty, and that patient was patient 1. So we have been able to collect all this data over time of all our patients, and this includes 7 full-time employees that call them to make sure we understand if they had complications and send x-rays so that we can actually analyze all these ideas. And I was very lucky to be trained by 2 giants of orthopedic surgery that Dr. Madsen, of course, knows really well. Bernie Murray is my second father. He's the father of elbow surgery. And Dr. Cofield was my mentor for shoulder arthroplasty, calf repair, instability, and everything I do for the shoulder. And today, we have a great group of people that I really enjoy working with. And we're very lucky to have Jennifer with us, who actually trained here with you guys for 1 year in trauma. When I was a fellow, one of my projects with Dr. Cofield was to look at the outcome of hemiarthroplasty for calf arthroplasty. And we look at a number of patients, as you can see, 33 shoulders that he had operated on. And I looked at the x-rays and the patients independently, and we realized that, when you have a patient with no calf and you do a hemiarthroplasty, the outcome is so-so. So motion improved on average from 70 to 90, and then 1 of every 4 patients still had pain. And I kind of wondered, we're doing this operation and this is my outcome. That doesn't work really well. Across the ocean, Dr. Paul Gramont had this idea, which was initially felt to be crazy, because all the implants that were constrained at the time had actually failed before. So when he had this napkin illustration saying, no, I think if we place the central rotation medial to the interface, it's not going to loosen up, and the momentum can be increased by 20% or 30% or 50%, people didn't believe him. And when he presented to Softcode, he was almost expelled from the room. But realistically, he completely changed the world of how we do arthroplasty today. So there is this famous quote by Soren Kierkegaard that says, life can only be understood backwards, but the problem is that we have to live it forward. So now I think we all think, reverse. Yeah, it makes so much sense. But for the people that were pioneer, they were really breaking ground. And in France, Dr. Gramont had this idea that he came up with that we call the Delta 3. That was the 3rd attempt. There was a Delta 1 and a Delta 2 that failed. And his idea was that if you place the center of rotation, which is the yellow dot, medial to the bone implant interface, when the patient moves the shoulder, there is no shear, there is compression. So that will probably make it easier for the implant not to loosen up. It was based on a central post. cementless exufixation. But if you pay attention, the humerus has moved medially. So then when the patient contracts the deltoid, if you have a very inclined polyethylene, it's going to dislocate. So he said, the only way I can make this work is if I make the polyethylene very horizontal. Then I can move the humerus medially. Hopefully there will be no loosening and maybe no dislocation. And this worked really well. I did a lot of Gramonte-style arthroplasty in my career, but there were some issues. The main one is that because the poly is so horizontal, it does collide with the pillar of the scapula and generates notching, polywear, and so on. Secondly, the deltoid gets better, the calf actually gets worse. When you medialize the humerus so much, there is loss of tension and momentum, so rotation function is actually compromised in the classic Gramonte-style reverse arthroplasty. And then the arm is lengthened substantially, and that can lead to deltoid stretch, stress fractures, poor cosmesis, sometimes brachial plexopathy. And then this implant at the time was not convertible. So you were going to try to decide intra-op anatomic reverse, you just couldn't do it. On the opposite side of the Atlantic, Mark Frankel, who is one of my best friends, had a completely different way to think about it, which was serendipity. So if you listen to Dr. Frankel's presentation on how he came out with his reverse, it's very interesting because he came back from France with a pamphlet that he gave the engineers of Denhau Medica, and he said, make me something like this. So it wasn't really his idea at the beginning to come up with the parameters that then became successful, but his design had a lateralized sphere, which allowed him to have a more vertical polyethylene, because if you lateralize more, there is less risk of dislocation, so you can go more vertical, and that decreases peripheral impingement and notching. And then his component was quote-unquote inlay, although you will see later on in the practice of this talk that that wasn't really the case completely. So starting from there, if we move now to 2025, to some extent, reverse arthroplasty is simple. When you go to the operating room and do a reverse for a patient, all you want to do in terms of your execution is to maximize motion free of impingement and optimize soft tissue tension, those two things. The first one, we understand. The second, we have no clue. So what is this perimeter impingement that arthroplasticians are talking about all the time? If you were the humerus and you're looking at the scapula, you can see how the coracoid is anterior superior, the spine is posterior superior, and the thickest portion of the pillar is inferior. So what would you do if you want to avoid touching the scapula? You will go away, so lateralize the glenoid, and you want to move inferior and posterior. That will minimize perimeter impingement. And we have learned that even though initially surgeons thought that the impingement happens when you have the arm in abduction, it's actually abduction and rotation. So when you're moving your arm in space to drive a car, to do whatever you want to do, then it's that friction that you can see in the pillar that can generate notching and that can eventually lead to loosening if you wait enough. Now that we are lateralizing more overall, you can also have impingement, which is bony, between the coracoid and the humerus or the spine, and that contributes to unexplained anterior shoulder pain and fractures of the spine and the acromion. So impingement is always talked about in reference to the poly and the pillar. It's also important in terms of the humerus, glenoid, coracoid, and spine of the scapula. And it's not benign. Patients that have more impingement will have less motion. Eventually, the poly wears out, and then they can lead to either instability or loosening. So what do we know will maximize motion free of impingement? A more vertical polyethylene, so Frankel-style prosthesis, I feel that is large, lateral, inferior, posterior, remove all the osteophytes, and then also watch out for impingement between the humerus and the acromion and the coracoid. Soft tissue tension, I would argue that we do not know how to tension a reverse prosthesis optimally today. My fellows are just ask me, how do you know this is the right polyethylene? Like, I actually don't know. I just go by feel, and I don't know how to explain it. I just go by feel. If you go back to second-year medical school and think about muscle physiology, we know that the human muscles were created so that the most active contraction happens in the resting state, because that's the situation where there is the potential for the fibers of actin and myosin to contract and really shorten. When you make a muscle longer, you increase the hydraulic pressure, and that increases strength to some extent. So you can see how, as we move to the right and make the muscle longer, strength increases a little bit because you're not combining active contraction and passive tension. But there is a point where you elongate so much that the fibers of active myosin can no longer contact. So you lose completely your active contraction. And no one knows what is the sweet spot. Most people say about 10%. And the key is to understand that this is maximally influenced by the other muscles. So for example, if you have a calf arthropathy patient that only has a teres minor, that muscle doesn't have to fight against any antagonists. But in a patient that has primary osteoarthritis with a calf intact shoulder, the muscles have to fight against each other. So that will dramatically impact the function of the teres minor. And we do know in different studies we've done at Mayo that every muscle of the shoulder is lengthened by a reverse. Dr. Frankel talks about an anatomic reverse that actually cannot exist. But the only muscle that gets a better moment arm is the teres minor, which is very relevant when we think about doing tendon transfers or not. So when we talk about advanced arthroplasty, we have to talk about different terms, and this becomes very confusing. So bear with me for a second, especially for the younger people or those who don't do arthroplasty, because before we talk about the different ways you can do reverse, you have to understand the terms. And in the human shoulder is simple. You can see that green dot is the geometric center of the humeral head. That's how the ball rotates against the socket. And then the tuberosity is somewhat distal, somewhat lateral. When we talk about reverse, it becomes very complicated. So if you draw a circle that best fits the glenosphere, you can see how the new central rotation is in that location, which is always medial to the human central rotation. So when people say, I'm doing a lateralized reverse, the CR is still medialized. So that's important to know. Something that we didn't talk about in the past, which I think is important, is where is the pivot point? The pivot point is where the deepest portion of the polyethylene meets the outline of the glenosphere. And then what is the angle between the polyethylene and the shaft? And based on that, you can start to measure a number of things. For example, you can measure how the implant is placed in the coronal plane. And most of us today want to see that our central fixation feature, a screw or post, is parallel to the radiographic projection of the floor of the subcutaneous fossa. So we call that a neutral inclination or beta angle. You can measure lateralization on the glenoid side two different ways. You can either measure from bone to CR or from bone to pivot point. From bone to CR has a major implication on impingement and loosening. From bone to pivot point has a major influence on calf tension and deltoid tension. So very different to understand what you're talking to me about when you say you're lateralizing this much. Is it the central rotation or is it the pivot point? And then the same thing is on the humeral side. You can measure humeral lateralization in reference to the axis of the humerus or to the greater tuberosity, and that will be affected by where the implant is. And then you can combine them into global lateralization and distal lateralization, distal position of the tuberosity. So as you can see, a lot of complicated terms that make this very confusing. But maybe the most important thing to remember today is that this surgeon is the method. So thank you, Dr. Madsen, because it doesn't matter what implant you use, you can always place it in a different configuration. So this is a picture from Dr. Frankel's landmark study on the 10-year outcome of reverse arthroplasty, where he says we used an inlay design. But his patients were little ladies from Florida, and the first DAO design did not fit in the metaphysis. So all those patients had an onlay reverse with an inlay implant, because you can see how the top of the implant is actually higher than the cut. So this implant was inlay by design, but all the data that we have from 10 years ago, most patients actually had an onlay application. The new implant is different. You can actually insert in the metaphysis that Dr. Xu knows very, very well. So when you go to meetings, people talk about, do you like to do 145, 155? Are you an inlay guy? Are you an onlay guy? Do you medialize? Do you lateralize? What's your capture ratio? And I think, like in many other things in life, this is not a dichotomous decision. There is actually a range. So the key is not if you do one or the other, is how much. So let's break them down in these four elements. Very important to realize that oftentimes the polyethylene is asymmetric in many implants, so the X-ray can fool you. You have to know what is the angle of the poly, not the angle of the humeral cut. Knowing that, there is basically two philosophies, the Gramonte style 155, Frankel style 135, and now many companies offer 145 as an in-between. And they each have pluses and minuses. Obviously, 155, more stable, more perimeter impingement, more distalization. 135, less stability, less impingement, less distalization. So in a patient that has a high risk of dislocation, you want to go more horizontal. So I use 145 in some of my patients. In a patient that has a calf intact shoulder that probably will not dislocate, and the patient maybe want to use the implant for the following 35 years, I want to go vertical. So I think the key as shoulder surgeons is not to say, I always do 135, I always do 145. No. For each patient, select the implant that is best for that patient. And regardless of that, the way you do the operation is going to dramatically change this. So this is a 145 implant. But if the surgeon places the implant in varus, now is 125. Dislocation is going to happen. Or this implant is placed in valgus, 145 now is 160. So you're going to have massive impingement. So very important to understand the principles of implant design, but how you as a surgeon apply them in the operating room. This is also something that I don't like, the idea of using inlay versus onlay, because no one has defined it clearly. But most surgeons agree that if you trace a line where the humeral neck is, and your pivot point is deeper to the humeral neck, you will call that inlay. And if it's over, you will call that onlay. But again, any implant can be made work as inlay or onlay. Medialize and lateralize, very interesting too. We did a study that showed that the question is not whether you medialize or lateralize, but how much and through where. Because if you take the templates of all the companies that are out there and you plot just based on templates how they lateralize, you can see the range. It can vary up to 2.5 centimeters, which is huge for a muscle to go through lengthening of 2.5 centimeters. So when you do your implant, you have to know your system, how much does it lateralize and through what? Is it through the glenoid or through the humerus? And then something that I had no idea about 2 years ago is that companies choose their capture ratio randomly. And I had no idea. So the capture ratio is how much of the poly is grabbing the sphere. And when the first implant came out, the PU Delta, the capture ratio of what they called a standard liner was 46%. That means that the poly was almost at the equator. And if you use a retentive, it was almost 70%. But if you measure the capture ratio of different companies, and there is 2 papers now, Philip Moroder and George Chadwell have published on this, every company uses a different capture ratio. So this is confusing because, for example, if you're a DJO user, your standard liner is 54% capture ratio, so it's pretty stable. If you now go to Perform, your standard is 46%, more instability. So again, now I think there is a push by companies to say, I'm not going to call them a standard or retentive. I'm going to tell you, surgeon, what is my capture ratio. And hopefully one day we'll have a uniform capture ratio across implants. Now that we know this, when we're now planning our surgery, when we look at the glenoid, where is it that we want to land? And again, this should be different for each patient. But in general, you're going to balance in your mind, I don't want impingement, I want to have good fixation, and I want to have soft tissue tension. If a patient has severe osteopenia, you may need to compromise on lateralizing so the implant doesn't loosen up. If the patient has rock solid bone, you can probably lateralize the hell out of it and it will never loosen up. No one agrees about where to place the implant 100%, but some surgeons talk about golden rules. I don't like this of golden rules. I think it's too rigid. But if you have a patient that has no bony deformity, so best example is massive calf tear without arthropathy. Typically, most surgeons want to see that the central rotation is lateral, about 5 millimeters, and there is some posterior and inferior overhang that you're matching native version and you're getting neutral inclination. So if you ever use pre-planning software like Matchpoint or Signature or Blueprint, most surgeons are trying to aim for these numbers as they start to plan in the shoulder with no deformity. You can get there 3 different ways. You can either do corrective reaming, which is what Dr. Frankel has done for years. You get a reamer at an angle because you want to be inferiorly inclined. Ream medially, then you are losing some lateralization, use a really large sphere. And that works really well. It's easy, it's very cheap. Potential downsides, you're going to medialize the pivot point, you lose bone, and because the pillar of the scapula comes into the neck, when you correctly ream inferiorly, you're making your transition more steep, so you actually increase perimeter impingement. So it's good, not ideal. Dr. Pascal Boileau has popularized something called the bone increase offset reverse shoulder arthroplasty, where he used a standard sphere and placed a bone graft as a sandwich between the base plate and the glenoid, and that can be at an angle. Benefits is super cheap. You're using the patient's own humeral head. It's super accurate. You're measuring within millimeters, and it gives you more bone stock. Challenges, it is more complicated, it takes more time. So North American surgeons that run 2 rooms don't like the idea of doing bio-RSA because it takes more time. And also, even though Pascal Boileau and others say we have zero concerns with graft healing, I've seen resorption. So I don't think it is foolproof. So in North America right now, metallic augmentation, I think, is the king. So the way that most surgeons are trying to correct all this deformity and get the reverse where you want is by using an off-the-shelf wedge. That you open the box and you have your graft made of metal in the back. The challenge is that an off-the-shelf component does not correct the more severe deformities. So if you have a very severe deformity, you need bio-RSA, or you can consider doing a patient match base plate. So this is something that I use out in my practice now, where if a patient has substantial deformity, I will place the base plate where I think I should place it. And then once I have my version and inclination where I want it, then in the computer program, you can compute the augment, and then we'll make you an envelope of metal that matches that patient's anatomy perfectly. So then you know before you finish the operation that this implant is going to be in the right location, yes or yes, right? Because you already placed it for the patient. And there is 4 companies now creating patient match implants for primary and revision arthroplasty. Benefits is easy, versatile, accurate, precise, bone preserving. You don't have to ream. The problem is that it's $1,000 more expensive than a regular base plate, and it takes 6 weeks to make. So there is some downsides, like with anything else, but in the OR, it's very, very easy to apply. And as you can see, your x-ray is pretty much perfect every single time. So now we have the glenoid where we want. You can do it 3 different ways: reaming, bone, metal, custom metal. What about the humeral side? Because we are now maximally lateralizing on the glenoid, we need an implant that has the pivot point at most at the cut surface. So if you lateralize on the glenoid a lot and your implant thickness is 10 millimeters, it's just too tight. You can always make it only by adding thickness to the polyethylene. So on the humeral side, most surgeons want to use an implant where, as you can see, the pivot point is at the humeral cut, so that's your starting point. Oftentimes, I find myself using a +3 polyethylene. So even though people say, oh, you use a flash lay implant, yeah, but I use it as in an only application many times. So otherwise, I don't think I have the adequate soft tissue tension. And one benefit of these newer designs is that one day we may or may not have successful stemless reverse, which is something that many people are interested in, and a more deeper ball with a deeper pivot point makes it easier for these type of implants not to loosen up. When shorter stems came into the market, the way that implants gain fixation was by making them bigger and bigger and bigger. So stress shielding has become a problem. So with these newer implants, you load the metaphysis only, and the distal aspect is very, very narrow. So hopefully that gives stress shielding. And it's pretty clear based on the Australian joint registry that modern polyethylene is going to really help us. So I think today, in 2025, most patients should probably get some type of improved polyethylene, vitamin E, or highly close link of other kind. And don't forget that we still love Anatomic. I like that line that people say, let's make Anatomic great again, like Donald Trump. So you want to have a system where if you have a reverse platform, you can always get your reconstruction of the head Anatomic. And that requires a lot of heads, a lot of sizes, and a lot of connections to make this work. Now, we talked about the fact that the technology is coming to us, and the next frontier of, I think, reversal practice, now that we kind of understand the science, is all these ways to execute the operation so that it's perfect. So you can see here an example of navigation, something that Exactech has pioneered. You can also do navigation with mixed reality, which I have used a little bit to get your pin in the right location using holograms. Another big question mark is if robotic surgery, which has become very popular in the field of hip and knee arthroplasty, is also going to make a dent in shoulders. I've been doing a few cases with robotic surgery, and I still don't know for sure if this is going to be dramatically changing my practice or not, but it's interesting to see how these technologies are coming into play in the field of reverse shoulder arthroplasty. However, as we said, reverse is still an art, because what we have not mastered is how to optimize the arthroplasty for the diagnosis or the patient. So some surgeons do the reverse prosthesis equally for every patient, every diagnosis, but they are so different. In a patient with capsular arthropathy, the bone loss is superior. The proximal humerus may be very high, difficult to relocate. The acromion is very thin, and the calf is gone. So probably we have to find a way to optimize reverse for capsular arthropathy, very different than a patient with primary OA, where the bone loss is posterior, the calf is intact, and the bone stock is rock solid. Very different than a patient that has an irreparable calf with no arthritis and good motion, where sometimes they are actually unsatisfied. Very different if you do a reverse for fracture, where you probably want to shorten the humerus a little bit to optimize tuberosity healing and lateralize less. So I think in the next 5 to 10 years, we're going to have two things to advance on. How do we optimize reverse for diagnosis and patients? And how do we execute properly our plan that is now so well done? And the same thing for patients. When people say, well, I'm going to lateralize 2 millimeters, that's very different in a patient that is 6'5", and the glenoid is humongous, or a patient that is 5'2", and the glenoid is tiny. So it depends on how big the patient is. Then we have the whole aspect of how do we incorporate the scapulothoracic position and motion in reverse. In the hip and knee, as you know now, pelvic tilt is very important for hip and knee. For hip arthroplasty, the same thing is true for the shoulder. And then the ultra-obese patient is a challenge because these patients dislocate all the time. So you have to find a way to, in that patient that is really obese, really aim for stability. And that may require to super lateralize these patients and maybe mobilize them a little longer. And then another complication of reverse, which is the insufficiency fracture of the spinal acromion, it depends much more on bone quality than implant geometry. We're talking about this, Jason and I, before we started. So I think we have to also understand that in some patients that are borderline anatomic or reverse, if they have osteopenia, maybe do an anatomic, and you don't run the chance of having this type of fracture that can be really complicated and difficult to solve for our patients. So in closing, it's pretty clear to me that this operation has really represented one of the most important examples of disruptive innovation in orthopedics. We have learned a lot. I really want to pay tribute to our pioneers because they were really innovative and found a way to do the operation differently. We now have mastered, I think, some of the science, but recognize that there is still an art in patient selection and implant configuration, which depends on which implant you choose, which are all different, and how do you apply it. Until we don't have a way to apply the implants perfect, we cannot really correlate implant position with outcome. But I think for you guys that are younger, I would definitely embrace AI and digital technology. That's part of the future for sure. But regardless of all that, remember that when you're in the OR or in the clinic, the patient is what matters. So forget about all your passions and things like that. It's important to do for each patient in front of you the best possible operation. Thank you very much. Happy to take any questions.
That's a great talk. Question about pre-operating. You go at that early. Sorry, you brought favorites. Breast lotion and needs like pre-operating on board something. Okay. What's your current approach to pre-operating taking those things?
Yeah, so I think, Jason, pre-op planning has been a major breakthrough, but it's very imperfect. I use it in every case, and the only thing I'm looking for is how can I optimize imperfect range of motion. That's the only thing. I don't trust that that's going to predict my motion. The scapula is not incorporated. We don't have any information on soft tissue tension. So it is helpful. It is also very imperfect. And one very important thing is that it can create a cognitive bias, meaning that in the screen, you can create a configuration that will maximize motion of your impingement by using a huge sphere. But if your patient is 5'2", you may never, ever have the exposure to get that sphere in. So I always have the patient's height, weight, diagnosis when I'm planning, not just the numbers, because the patient's geometry is very important as well.
So, maybe doing broad permanent stress fractures also you should have gotten rubber dollar planning. What kind of factors are you looking at in terms of the positioning of your implants? You're planning for someone who's saying osteopenia, maybe has already one or two years later, particularly like proceeding at the length or the total length, double extension of the acid extension is more stressor on the acromion, or possibly decreasing the mode on the development as well as all of the excessive force.
Yeah, that's such a great question. I can talk about this for like hours, but I'll give you a quick answer if I can. So number one, is not clear to me that distalization is the only way that these fractures happen. There are some surgeons that believe, including me, that some of the fractures has because you have repetitive collision between the GT and the acromion. So as you know, what's happening to the acromion is that it's moving multiple cycles and it finally breaks. In some patients, probably because the deltoid is pulling too much, I agree. But in some, it may be because you have that impingement that is constantly bugging them. And I have a couple of patients that fractured doing therapy, where they felt they were going like this and, it hurts, you know. If you look at the odds ratio of the tables of the papers that have reported on risk factors, the odds ratio of rheumatoid, for example, can be all the way up to 15. That means that a rheumatoid patient has 15 times a higher risk of fracture of the acromion of the spine. If you look at the odds ratio of lateralization, sometimes it's 0.01. So I think we fool ourselves when we think that we can dramatically change the chance of a fracture by just changing the implant. I still do it, but I'm not sure that if a patient has severe osteopenia, I'm going to really change the outcome. So if I have a patient that I'm worried, I try to lateralize and distalize less. I try to avoid the screw going up into the spine, like everything we do. I counsel them. But my best weapon is actually do an anatomic in that patient if I can. So if I have a rheumatoid patient that has a reasonable cuff, I'm going to do an anatomic because anatomic in rheumatoid works really, really well. And today, a fracture of the spine, it doesn't really have a great solution. We reported our data on ORIF and we had a 20% failure rate when we plate them. And this is with 2 plates, bone graft and everything. Dr. Madsen?
Thanks so much. I'm interested in your reports to rehab. I was like once they line we're talking healthcare involved minimizing the risk fractures and also minimize the risk.
Yeah, so for those patients, I actually try not to use the help of a physical therapist. So as you know, Dr. Neal talked about limited goals rehabilitation early on in his career. And on those patients, I try not to send them to a therapist. I just explain to them what they should do. Because to your point, when a therapist is kind of really cranking on the shoulders, where I think they can increase the stress, and once they fracture, it's so difficult, you know. For the patient that is at risk for instability, I immobilize them longer as well. And I try to explain to them how to avoid motions that can get them at risk. And I will increase the capture ratio, use a more horizontal polyethylene, and lateralize more. Well, thank you very much for welcoming me, and I'm interested to listen to the reasons of the residents now. Thank you.
Next, we're going to transition to the resident research presentations. First up, we have Nate Benner presenting his work on Achilles tendon tears.
That thing like bigger. Oh no, just do like this. Yes.
Perfect. All right, good morning, everybody. I'll have to start by apologizing. I don't think my animations are nearly as good as Dr. Sanchez-Sotelo's. My name's Nate Benner. I'm going to be talking about our study on percutaneous Achilles tendon repairs, and this is a biomechanical analysis of suture type and configuration. To start, I do not have any disclosures, and there are no relevant disclosures for my co-authors. The Achilles is a large tendon, and injury is relatively common. Achilles tendon ruptures have an annual incidence of about 29 per 100,000 person years, and there's controversy over the indications for performing Achilles tendon repair. There are multiple prior randomized control trials and meta-analyses that compare non-operative to operative treatment, and there's no clear difference in outcomes. However, there's recent articles, including one in the New England Journal of Medicine, demonstrating a higher risk of re-rupture in patients treated without surgery than in those treated with open or minimally invasive surgery. And there's also an earlier return to sport with surgery and a potentially better lift-off strength at 1 year after surgery. So given these suggested benefits, many patients, including recent sports athletes in the popular media, undergo operative management of acute Achilles tendon ruptures. And failure of operative treatment leads to prolonged time away from sport and the possible need for a revision treatment, which can be a significant undertaking. So broadly, surgical management of the Achilles tendon, is performed with open or minimally invasive techniques. Minimally invasive surgery consists of small incisions with sutures placed percutaneously through the Achilles tendon. And in recent years, this has become more popular with the trend towards minimally invasive surgery and concerns about wound complications with the traditional open approaches. So construct failure leads to prolonged recovery and the possible need for revision surgery. And little is known about the biomechanics of different suture configurations, but it's been shown that the addition of a lock suture can lead to a greater construct strength for both cyclic and ultimate load to failure. The standard construct uses 1 locked and 2 non-locked sutures, and there are no prior studies that compare round suture to taped suture or the use of double lock suture to single lock suture. Understanding this, we believe, can help us make decisions about what type of suture to use and what configuration for our patients. So the purpose of this study was to evaluate the biomechanical strength of 4 suture permutations using a porcine flexor tendon as a model for a human Achilles tendon. We hypothesized that double locking configuration would be stronger than single locking, and that suture tape would be stronger than round suture. So for this study, porcine toe flexor tendons were used as an analog for the human Achilles tendon. They have been shown in similar anatomic and physiologic properties to human tendons and have been used in several previous studies that looked at the mechanical properties of the Achilles tendon repairs. Tendons were sutured according to a predetermined protocol and then cut to simulate an Achilles tendon rupture. This is a schematic that shows sort of the method that we used. The first suture was positioned to allow 1 centimeter of space between the cut end of the tendon and the first suture in the configuration. And the suture closest to the cut end of the tendon was either a simple single locked or a lock suture, which was double locked. And I'll show a schematic in a second that helps to illustrate that a little bit better. The middle suture was always a lock suture, and the suture furthest from the cut end was always a simple suture. There was at least 2 centimeters of tendon between the last suture and the end of the tendon to allow for loading onto the mechanical testing machine. So this is a schematic demonstrating this. At the top left, you can see single locked round suture, group 1. So the red sort of little thing that looks like a knot represents the amount of locked in the tendon. So the top left, you can see we used round suture and we locked it only once. On the top right, you can see we used tape suture and we locked it only once. And then the double locked was the ones on the bottom left and the bottom right, which we used either round or tape suture. And there were a total of 40 tendon repair constructs, and they were randomly assigned to each group, 10 in each. Specimen constructs were then unilaterally attached to a material testing machine by mounting the proximal and distal ends in a 3D printed clamp. The clamps were placed 5 millimeters from the most distal end and the most proximal stitch on the specimen construct. And then a 1 Newton static load was applied, and the cross-sectional area of the tendon was determined. This was followed by static creep, dynamic creep, and finally load to failure testing. Okay, after confirming normality of the data set, an analysis of variance test was performed to assess if the repair type had a significant effect on the mechanical properties of the tendon repair construct, with the biomechanical variables modeled as dependent variables and the repair type as the independent variable. And this was followed by a pairwise comparison and independent t-test to assess the intergroup differences and if significant effects were found, and they were adjusted for multiple comparisons. Okay. For static creep, there were no significant differences found on strain measurements during the static testing, and no gap formation was seen in any of the specimen after this test. And just to explain a little bit about static creep, static stress relaxation is the most common method of evaluation of viscoelastic properties of tendons. This protocol involves application of a linear ramp increase in strain, followed by a hold period at subfailure strain, wherein the load is measured to quantify time-dependent relaxation. And then similarly with cyclic creep, there were no significant differences found for strain measurements during the cyclic creep test and no gap formation. And when you study cyclic creep, there's a cyclic variation in the amount of load applied, and then there's accumulation of plastic deformation due to the cyclic mechanical or thermal stresses. However, with load to failure testing, we did find some significant differences. So the repair type that we used had a significant effect on the maximum load to failure of the constructs. Pairwise comparisons showed that double tape had a significantly greater load to failure than single tape in single round conditions. No significant difference were found between the double tape and the double round, nor the double round in any of the single techniques. For those who are not used to looking at box plots, which I was not used to looking at prior to this study, the box represents the interquartile range. The bold horizontal line represents the median value, and the whiskers are the outlier data. So you can see here the green box and its median are above the blue and the purple boxes representing the double tape being superior. We also looked at stress at failure, and similarly, the repair had a significant effect on the maximum stress in the construct during the load to failure test. Pairwise comparisons showed that the double tape repair reached greater stresses before failure compared to the single tape or the single round sutures. No significant differences were found between the double tape and the double round or the double round in any of the single techniques. So double locked tape configuration showed significantly higher load to failure compared to the single locked and single round, and double locked round was not shown to be superior to single locking, and suture tape was not superior to any of the round sutures. So the results suggest that the use of double locked tape suture configuration may lead to a stronger overall construct. Use of double locking suture construct adds little time to the surgical treatment of Achilles tendon ruptures, and it can add strength to the surgical repair at time zero. And one can consider using this construct in patients who may be at higher risk for re-rupture, such as a competitive athlete or patients who are expected to put an increased stress early on their repair and their recovery. So to discuss some limitations, although the use of porcine tissue as a surrogate for human Achilles tendon has been validated in previous biomechanical studies, there may be some limits to the generalizability to in vivo use. The biologic effects, such as healing human tissue and suture breakdown during the course of the postoperative, and suture breakdown during the postoperative rehabilitation can't be assessed with this method. Additionally, we chose a minimum distance between our cut and the end of the suture, and in a surgical patient, the location of the rupture may dictate the amount of tendon available to do the suture configuration. And then finally, we sharply cut our tendons to create our Achilles tendon rupture. While in vivo, these are often the result of stretching or pulling mechanisms. But the hope is that we still can gain some insight into the stress and a repaired tendon sees while it's undergoing load. Future studies would aim further to understand the differences in these suture configurations. One study may use human Achilles tendons with a cadaver model, which would better approximate the in vivo conditions with skin and true Achilles tendons. And if this difference is substantiated, designing a prospective human study would be kind of the next step in that phase. And then it's also important, I think, to understand how much these differences make a difference for actual patients. So the difference that we saw was only a 70 Newton difference in maximum load to failure. So, some studies have quoted up to 3,500 Newtons before a rupture of an Achilles tendon actually happens. So those would be like sort of the next steps. Take any questions?
In addition to the generalizability of it, there's also maybe there was a lots of study. Was the value the same for all of the testing with either breaking or pull up, or were you seeing the quality of the tissue being a factor versus the volume of the tissue?
Yeah, I think all the ones that we had fail were from pulling out of the tendon.
What effect quality of the tendon? The application results, but it's roll tendons to your lap. We're not dealing with the whole tendon.
Yeah. So I think that's definitely one of the limitations to the study, but usually when we're doing Achilles tendon repairs, we're searching for the most normal portion of the tendon that we can put the sutures through. But definitely they're going to have undergone stretch during the initial failure. So I think that's probably a major difference between the study and the actual in vivo use.
In the old days when I surgery, I was always impressed I share two lockers, front put together in a six, quite different in a second.
Totally. Yep. All right. Thanks.
All right, next up, we have Dr. L. Bowie presenting her work on A1 pulley releases in rock climbers.
Morning, I'm Gabrielle Bowie, and today I'll be presenting on how the release of A1 pulley decreases the force to pulley rupture in climbers. I don't have any relevant disclosures. Rock climbing has long been a part of mountaineering, but it's thought to have evolved into its own separate recreational activity by the end of the 19th century in Europe. Over the last several decades, rock climbing has increased dramatically in popularity, with over 44 million people climbing today regularly. It was even added to the Paris Olympic Games in 2024. I'm sure many people in this room either are or have friends who are climbers. Previous studies amongst recreational climbers have found that 30 to 50% of climbers have a climbing-related injury at some point. In elite climbers, 41% of those injuries involve either the hand or the finger, and almost half of those injuries involve the pulley system. This is thought to be due to the crimp grip, which is characterized by maximal flexion at the PIP joint and maximal hyperextension at the DIP joint. This allows climbers to maximize grip surface area on small folds. Trigger finger is common, with a prevalence of 3% in the general population and 5 to 20% in diabetics. This can be treated surgically with the release of the A1 pulley. And while this is a safe and very common procedure, it does have a rare but serious complication of bowstringing, which can cause significant disability and need for reconstruction. So while it is known that climbers are at a uniquely high risk of pulley injury, and while trigger finger is common, no research has been published to understand how the release of the A1 pulley to alleviate trigger finger changes a climber's risk for rupturing other annular pulleys. This is the question that we set out to answer. As this research question is focused on a very specific patient population undergoing a single procedure, and given the potential morbidity of pulley ruptures, we chose to investigate this question using a biomechanical model. Our hypothesis was that by releasing the A1 pulley, we would decrease the amount of force to rupture A2 and A4. Our primary outcome of interest was the amount of force to rupture A2 and A4, and our secondary outcome of interest was the timing of rupture of A2 and A4. We had 6 pairs of fresh frozen cadaveric upper extremities. 2 were female, 4 were male. The mean age was 41, and the average weight was 73 kilograms. Our donors did not have any known history of upper extremity surgery. The specimens were dissected to expose the flexor pulley system, and a radiocarpal disarticulation was performed. The FDS and the FDP tendon to each finger were then sutured together with a Krakow style and O fiber wire. Each specimen had 2 A1 pulleys that were released on the right and 2 that were released on the left hand, with the corresponding pulleys intact on the contralateral side. We excluded the thumb due to limitations with the jig. The A1 pulley release on each pair of specimens was then sequentially reversed for the next pair of specimens just to mitigate any changes or differences in handedness or finger strength. A custom jig was used to test the failure load of the pulleys. The hands were secured to the jig in the crimp position, and the clamps were used to attach the tendons to a force transducer that was then linked in series to a load actuator. An endoscope was positioned to visualize the pulley system, and then that video was synced to the force recording. For each hand, fingers were tested in the order of the middle, ring, and small fingers, and then the order of the hand side was randomized. The load actuator was moved at a rate of 10 millimeters per second until the pulley failed, or if there was some other component of the setup that failed, such as if there was a fracture or dislocation or slippage of the clamp. After assessing the data for normality, we then used a paired t-test to assess the statistical difference between the pulley strength for the release and the unreleased fingers. Here you can see a video demonstrating our testing protocol. Prior to testing, we had a few specimens that we used just to hone our technique. This was a process of trial and error. We had to create a setup that would work for hands of different sizes, keep the hand in the correct position, keep the clamp from slipping, and also allow for adequate visualizations of the pulley that we were stressing. We started with 24 paired fingers. We excluded 15 due to undesired events such as fracture, dislocation, and failure of the clamp. And then we saw that there were more failures in the small finger just due to challenges with stability under load that led to several dislocations and fractures. Pooling the data from all the fingers, the force to rupture A2 and A4 was decreased by 98 newtons, and we found that A2 and A4 ruptured almost simultaneously. Specifically, by pulling all the fingers, we found that the mean amount of force to rupture A2 and A4 decreased from 685 newtons to 588 newtons with the release of the A1 pulley. Unfortunately, our sample size was too small to reach significance for the individual digits. Again, overall, we found that by releasing the A1 pulley, we decreased the force to rupture A2 and A4 by 98 newtons. And this represented a 14% reduction in the force to rupture, and this was statistically significant. Given that previous studies have found a load of 225 to 287 newtons along the A2 and A4 pulley when in the crimp position, this may represent a clinically significant difference as well. This study is relevant largely in the setting of patient education. As we previously discussed, climbing is an increasingly popular sport, especially in places like the Pacific Northwest. And given the frequency with which we're performing A1 pulley releases, it's critical for us to understand how the release of A1 can affect the rate of pulley rupture or the risk of pulley rupture of A2 and A4 in climbers. There were limitations to this study. It was a small study. We had 6 paired cadavers, but we had an adequate sample to find a statistically significant difference when we pulled the data. We had a large percent that were excluded from the study. The fingers were loaded individually, and we crack out FDS and FDP together. And these are all limitations related to doing a biomechanical study with a custom jig. And while the jig was not perfect, we were able to create a testing environment that kept the hand in the crimp position while applying increasing force, which is our original goal. And then, as with any biomechanical study, there's a question of how does this relate to in vivo findings? But we believe that a 14% reduction is probably clinically relevant, especially given the high loads that are seen in the crimp grip among elite climbers. And then I think it just makes intuitive sense that if you have a pulley system and you remove one of the pulleys, there's going to be increased load on the others. And this is consistent with what we found. In conclusion, this is the first study, to our knowledge, to investigate how the release of the A1 pulley impacts the amount of force to rupture A2 and A4 in the crimp position. And given how common trigger finger is, it's important for us to learn how to educate climbers regarding the management of trigger finger. So what should you do if a climber comes into your clinic with trigger finger? We recommend an aggressive trial of non-operative management, including steroids, injections, and bracing. If a patient continues to have symptoms, we recommend release of the A1 pulley, but with education preoperatively about the risks for rupturing A2 and A4, and with delayed return to climbing. Further research is required to guide our postoperative protocols after A1 pulley release in climbers. And with that, I'd like to thank you for your attention, and I'd be happy to take any questions.
How effective is steroid injecting?
So it depends on the patient's risk factors. So it's less likely to be effective in patients with diabetes, and it's less likely to be effective in the thumb. But as to the exact rate of the efficacy for long-term management, I'd have to look at the specific numbers. I don't remember off the top of my head.
Is that We're at Tendon Rockers. It's the early blood point out. What I would their point, but also great studies, quite hard to do these. That's interesting way to say. Studies that's also that's right. What's race? Please, guys. The other point, you let some. That's very hard to grow with. Here's rational. You want to pull it. That's the fun. Being at the hospital level, there's national basis. There's it just growth.
Yeah, that would be a really interesting thing to look at. It's just, especially I think in the climbing community, it's such a specific patient population and such a specific problem. I personally haven't come across any literature regarding that question.
The other thing about this problem is the climbers are very soft.
Yeah.
Where
Mhm. Thank you. No.
All right, next up we have Eli Bunzel, who's going to be presenting his work on thoracolumbar fractures in patients with ankylosing spinal disorders.
Thanks, Dr. Yang. All right, good morning, everyone. My name's Eli. I'll be presenting on our comparison between open and percutaneous stabilization of thoracolumbar fractures in patients with ankylosing spine disorders. I have no relevant disclosures. So ankylosing spine disorders characteristically result in autofusion of the spine, leading to abnormal rigidity and a long lever arm. This can predispose patients to a significant injury from even minor trauma. And in fact, individuals with these conditions face a fourfold increased risk of fracture compared to the general population. These patients are typically of advanced age and have multiple comorbidities and are at an increased risk of neurologic injury and bleeding. Surgical management of spine fractures in this vulnerable population is associated with higher rates of perioperative complications and a greater one-year mortality risk. The AO Spine thoracolumbar injury classification system was created to classify thoracolumbar injuries by morphology with increasing severity from compression to distraction and translation. The AOB3 subtype is characterized by a tension injury of the disc, vertebral body, or both, resulting in a hyperextended, distracted position of the vertebral column. This morphology is most commonly seen in these patients with ankylosing spinal disorders. So treatment of these fractures historically consisted of open instrumented fusion at least 2 to 3 levels above and below the level of injury, or more with multi-level involvement. While early stabilization has been associated with quicker recovery and improved outcomes, patients are still at high risk for intra and postoperative complications such as infection, dehiscence, as you can see here, and significant blood loss requiring transfusion. Minimally invasive surgery has gained popularity in the treatment of these injuries, as it's been associated with decreased blood loss, operative time, and perioperative complications compared to those traditional open approaches. This is a particular interest for this particular patient population, which tends to carry with it a higher comorbidity burden and, like I said before, more advanced age. So the purpose of our study was to compare intraoperative and postoperative outcomes between open and percutaneous fixation of these particular injuries. Specifically, we wanted to look at our own institutional experience at a high volume level 1 trauma center that sees these injuries more frequently than the majority of the country, as we began to shift our practice from open to percutaneous stabilization. This was a retrospective review of adult patients with ankylosing spine disorders presenting with thoracolumbar hyperextension injuries to a level 1 academic trauma center that were treated operatively over a 15-year period. Patients were divided into 2 cohorts, open and percutaneous fixation. We collected demographic, hospital, and postoperative data. We analyzed the 2 cohorts using independent sample t-tests and Fisher exact tests. And then we additionally conducted a multivariable regression analysis to assess which factors contributed to an overall negative outcome. So a total of 200 patients met our inclusion criteria. 174 patients underwent open stabilization and 26 underwent percutaneous stabilization. The mean follow-up was 158 days in the open group and 78 days in the percutaneous group. There were no significant differences in patient demographics, health status, or tobacco and drug use. The number of instrumented levels fused was significantly different between the 2 cohorts, as you can see at the bottom of this table. Our overall surgical site infection rate requiring a return to the operating room was 11%. Despite the difference in infection rate between the 2 cohorts, we did not find any statistical significance. Time in the operating room and estimated blood loss were significantly higher in the open group compared to the percutaneous group, which is what we expected to find and is consistent with previous literature. We pooled our surgical site infection, 90-day mortality, and 90-day reoperation data to determine differences in overall negative outcome. However, we did not find significant differences here either. Now, surgical invasiveness index is a previously validated instrument that accounts for the number of vertebral levels instrumented and the surgical approach. Patients with higher surgical invasiveness index scores have a greater risk of surgical site infection, requiring return to the operating room for treatment. This was found to be significantly different between the 2 cohorts in our study. In addition, we conducted a multivariable logistic regression analysis to determine whether there were any patient or operative factors that correlated with or were protective against a negative outcome. This, however, also failed to demonstrate any significant correlation. So I believe our data demonstrates findings consistent with previously reported studies, including decreased OR time and estimated blood loss in the percutaneously fixed group. But additionally, we showed significant decrease in the surgical invasiveness index in the percutaneous population. I believe this is early in our institution's experience, and with more patients undergoing percutaneous stabilization every year for these injuries, we'll continue to analyze outcomes to determine safety and efficacy between the 2 treatments. Of course, we need further studies in order to better analyze the difference. And I also want to just emphasize that treatment strategies should be tailored and personalized to each individual patient based on their presentation and specific needs. These are my references, and thank you very much for listening.
Like, Suture and the machine is saying, where the skill and what you feel. Everything is making general comment. We are learning or lose. Anybody that was public, it comes in with shine. Very over and over and this round. I'm interested in that.
So in terms of percutaneous stabilization, that encompassed both navigation techniques, even though surgical navigation doesn't always equate to percutaneous fixation. Sometimes it's done with an open approach. We consider percutaneous either using robotic techniques, which we're also slowly incorporating and have been over the last 2 or so years, as well as just small incisions the same way that we fix lumbopelvic fractures in the spine as well. Thanks, everyone.
Next up, we have Dr. J.D. Gatto, who will be presenting his work on Ream-and-Run Arthroplasties.
Hi, everyone. My name is JD. As I was introduced, appreciate that. We'll be talking about recreation of proximal humeral anatomy and shoulder arthroplasty, specifically in Ream-and-Run hemiarthroplasty. I have no disclosures yet. So first, we'll start by reviewing one technique for shoulder arthroplasty known as the Ream-and-Run arthroplasty, which encompasses using a proximal humerus hemiarthroplasty paired with a componentless glenoid arthroplasty. In Ream-and-Run arthroplasty, the surgeon reams the glenoid, focusing on the humeral head's rotation within its new surface. This differs from total shoulder arthroplasty in that there's no polyethylene component used. The amount of the bone that is reamed can affect the kinematics of the joint, so it's important to be mindful of that. And the desired response is seen in the image above, which shows a remodeled fibrocartilage surface and a more concentric joint. Additionally, we have to know more about using recreation of the proximal humeral anatomy and how that has an effect on postoperative outcomes. Stiffness is a known complication of this, and we see this as a function, or we believe it to be a function in part due to glenohumeral joint width, as seen in that illustration. So as I alluded to, recreating the proximal humeral anatomy is critical in all shoulder arthroplasty. What we want to do is optimize sizing and positioning of the humeral component, and over sizing can lead to a concept called overstuffing, which can change the biomechanics of the glenohumeral joint and have significant effects on the range of motion seen in these patients postoperatively. One commonly used method of recreating proximal humeral anatomy is the perfect circle technique, wherein 3 points are created with a circle using the medial calcar as well as the medial aspect of the greater tuberosity and the lateral cortex of the greater tuberosity as well, and drawing that circle. And then we compare that to the change postoperatively in the center of rotation, and that can give you an idea of how much you're changing the proximal humeral anatomy postoperatively. So why do these patients get so stiff after surgery? So one positive theory is too large of a humeral head component can be contributive as well. Too large a diameter of a humeral head component could also potentially impinge on the cuff or also change the biomechanics of the proximal humerus. Too high of an osteotomy can also have an effect, causing changes in lateralization of the proximal humerus as well as impinging on the cuff superiorly. Or in stem prosthesis, placing the component in varus can then change the center of rotation as well. So all these things are things we keep in mind when we're placing these components, but it's sort of, as was alluded to in the first talk, a little bit of art and science and sort of a feel for things and balancing stability and range of motion. So the existing literature on this shows that there is a cadaver study that showed that, excuse me, advanced too early, that increases in humeral head diameter can reduce laxity and motion. So the concept being that that can lead to increased stiffness. Another study also showed that even smaller changes in humeral head diameter can do this, affecting translation, rotation, and elevation. And then while those were in cadaveric studies, one retrospective study then looked at total shoulder arthroplasty and found that changes in the center of rotation actually don't change the functional outcomes after total shoulder arthroplasty. So where does that leave us in our research question today? So what we sought to find out was what effect do changes in this proximal humeral anatomy have in Ream-and-Run shoulder arthroplasty specifically, and in terms of the risk of returning to the operating room to address stiffness. We hypothesized that changes that increase the offset or overstuffing the joint in the coronal plane will result in increased stiffness postoperatively. So our methods were a retrospective review of Ream-and-Run arthroplasty with a minimum 2-year follow-up. We used standardized x-rays using Grashy views both pre and post-op. And patients were grouped as either stiff or non-stiff. Stiff was defined as patients who returned to the operating room requiring manipulation under anesthesia or revision arthroplasty. And we analyzed the data with a univariable and multivariable logistic regression. Our flow chart shows here excluded some patients for inadequate radiographs, but otherwise we included 108 patients, which then we have these smaller numbers, but they show that patients did have to return for revision arthroplasty or manipulation under anesthesia. So in looking at what we measured, there are different parameters that we were measuring. We used a standardized X-ray of the shoulder and Grashy views and an overlying transparent grid and circle that was fit to the articular surface of the humeral head, and then we changed the magnification of the image to do so. We standardized that against the postoperative images, knowing the size of the implant that was used relative to the humeral shaft, because that does not change pre to post-op. And we were able to calculate these measurements and how they were existing preoperatively, postoperatively, and then the change between the two. So one was the medial humeral head to the center of rotation. Another one was the medial humeral head to the lateral cortex. Another one was the acromion lateral cortex to lateral cortex, or the humeral offset, and then humeral head height in this index here. We also calculated the volume of that. First off, that equation scares me every time I look at it, but we calculated the volume of the humeral head after osteotomy to account for sort of that quote unquote dead space that is between the known implant size and where the osteotomy was performed. So what did we look at? We looked at these measurements here with a univariate analysis. While there were lots of different measurements we looked at, 3 then ended up being significant on the univariate analysis, the pre-op humeral offset as well as the neck shaft angle. And then we saw that the change from pre to post-op for the neck shaft angle was also significant. And looking at the univariate analysis, we can see that the decreased humeral offset preoperatively was associated with an increased stiffness risk. We also saw that neck shaft angle was significant as well. That higher neck shaft angle pre-op was associated with increased risk of stiffness, at least in the univariate analysis. Also the change between the two showed that big change from into postoperative varus was associated with increased predictor of stiffness. Those are a univariate analysis. So we took those and that were significant and put them into a multivariate analysis, but we did not find that these in and of themselves were significant in the multivariate analysis. So in discussion, increased preoperative valgus and large neck shaft angle change may contribute, but again, wasn't significant on multivariate analysis, but may have some contribution. Medial and lateral dimension can impact stiffness, but it's probably not alone, as we see that it seems to be on concept and in sort of our understanding while we're performing these surgeries, but not yet sort of flushed out by the data. And no association with humeral head height or capsular volume was found to be significant in terms of risk factors for stiffness. We did have some limitations of our study. First, it was radiographic analysis was limited to the coronal plane, so we weren't able to assess the A to P plane for these, or the three-dimensional analysis other than the volume, which was sort of a surrogate for that. We also didn't account for any soft tissue tension or balancing that was performed intra-op. And stiffness was only sort of grouped into or it was defined as the need for an MUA or a revision, but this may underreport people who are stiff but did not undergo a procedure to address this. So some takeaways, radiographic parameters alone are not sufficient to predict stiffness, but may contribute to how we think about these, and recreation of the proximal humerus anatomy remains important, but not the entire story. Thanks for your attention.
The Everson Berkeley for these UAs of the city on the stereo. The crazy they wrote.
This was how we had captured them within the study. Was just that's what unfortunately it was a limitation in that way. And there may be folks that are more stiff that may benefit from a repeat procedure that again might undercapture. Not that I'm aware of. Mhm.
There was a big study, and you may not have it. Do you know revision surgery and manipulation? Well, effectively great. Even from the United States and basically one with manipulation or surgery or the emotional system, namely that's over some either.
I don't necessarily have any data to show regarding that. Obviously, anecdotally, we find that some patients do better and some patients don't. And we know with Ream-and-Run arthroplasty specifically, a big component of this is the patient's motivation to go through the rehabilitation process. So I think that that's certainly a factor, but I don't have any data regarding that. Mhm. And then I think Corey has a question.
The Joe
Right.
drawn the perfect circle. Like it is based off. It's a little bit on the shoulders, the both. There's an important difference between we're almost because we're addressing four leaders off that we whereas more.
Mhm.
And it's most advised measure for heavy arthroplasty. We're curious about keep taking some we're saying someone who was shoot a perfect circle for a heavy arthroplasty or inside the root change in the humerals.
I think that's some of the challenge that we face is that all of your adjustments are living aside from your reaming and how much you ream for the reaming for the Ream-and-Run. All the change that you're making in especially in the coronal plane will be with your proximal humerus reconstruction. And so that was our thought with this study, was to try to use other parameters that you might be able to measure more reliably to see if there was an increased risk factor for stiffness. So changes the way we think about it compared to totals. And this is sort of a different way to think about that. Thank you.
Next up, we have Dr. Arthur McDowell, who's going to be talking about the impact of charity care on total joint arthroplasty outcomes.
Good morning. I'm Arthur McDowell, and I will be presenting my research on the effect of charity care financial assistance on 90-day postoperative outcomes following total joint arthroplasty. I have no disclosures yet as well. As we all know, total joint arthroplasty has become one of the most performed orthopedic procedures and typically yields favorable outcomes for patients. The efficacy and volume of total joint arthroplasty has stimulated increased attention to outcomes and disparities. Previous studies have demonstrated that patients with Medicaid and Medicare are more likely to have an increased risk of mortality, complications, readmissions, and discharges to institutional care when compared to patients with private insurance. Additionally, there have been more studies that have demonstrated that traditional socioeconomic metrics like insurance, income quartile, and area deprivation index, which are commonly used to predict total joint arthroplasty outcomes, may not fully capture a patient's socioeconomic vulnerability. Despite their widespread use, these traditional socioeconomic metrics have notable limitations. Insurance status alone fails to account for income variability, overall financial resources, out-of-pocket healthcare costs, and geographic differences in Medicaid eligibility, all of which impact financial stability. Income quartiles and census-derived indices overlook heterogeneity within income brackets and geographic areas, therefore lacking the granularity required for a precise assessment of a patient's socioeconomic stability. For example, the Area Deprivation Index combines multiple indicators to create a single score that reflects the overall socioeconomic disadvantage of that neighborhood. Individuals that live in the same neighborhood can have very different socioeconomic stability. Therefore, financial assistance has been considered an additional socioeconomic metric that may have a better tool to evaluate socioeconomic stability. So, to the best of our knowledge, no study has assessed the effect of institution-based financial assistance on outcomes. Our institution, in particular, provides charity care financial assistance to qualifying patients at or near the federal poverty level. This is irrespective of insurance status, and this program covers the cost of care without obligation for repayment. The primary aim of our study was to evaluate the impact of charity care financial assistance on 90-day postoperative outcomes following total joint arthroplasty. We hypothesized that charity care status will be associated with worse postoperative outcomes, including increased medical and surgical complications, and that this would be a stronger predictor of adverse outcomes compared to other socioeconomic metrics like area deprivation index. We performed an IRB-approved retrospective review from January 2004 to December 2022 for patients who received charity care financial assistance and underwent primary total hip arthroplasty or total knee arthroplasty at a single academic institution. Patients were excluded who underwent revision total joint arthroplasty, arthroplasty due to traumatic fracture, had a history of hip dysplasia, or who had primary or metastatic bone malignancies necessitating hip or knee arthroplasty. Charity care eligibility was determined by the providing institution based on the federal poverty level guidelines and was adjusted for family size and income up to 400% of the federal poverty level, with patients required to exhaust third-party liability coverage like Medicaid and Medicare before receiving any financial assistance. So a manual chart review was then performed to collect patient information, including demographics, comorbidities, surgical data, hospital stay, and postoperative outcomes. The postoperative outcomes of interest that we evaluated were 90-day readmission, reoperation, emergency department visits, hospital length of stay, discharge disposition, medical and surgical complications, and cumulative postoperative complications. Postoperative complications were categorized as either medical or surgical. Medical complications included 90-day mortality, stroke, acute respiratory distress syndrome, urinary tract infection, deep vein thromboses, pulmonary embolism, and altered mental status. Surgical complications included 90-day manipulation under anesthesia, prosthetic joint infection, periprosthetic joint fractures, dislocation, debridement, antibiotics and implant retention, i.e. DARE, and reoperations not classified as DARE. The charity care cohort was then matched to a control cohort of patients without charity care status in a 1-to-3 ratio based on age, sex, body mass index, Charlson comorbidity index, and the calendar year of the index surgery. This resulted in a charity care cohort of 312 patients with 149 total hip arthroplasty patients and 176 total knee arthroplasty patients, and a control cohort of 936 patients. In the charity care group, the mean age was 58 years, BMI of 31, and 57% were female. The control group had a match to this. All the patients included in our study were seen for follow-up at or near the 90-day mark. After matching our charity care cohort to our non-charity care controls, we found that patients who received charity care had significantly higher odds of 90-day readmission, reoperation, ED visitation, and discharge to a skilled nursing facility on multivariate analysis. Hospital length of stay did not significantly differ between the two groups. We also found that patients who underwent charity care had a higher odds of all complications, including surgical and medical complications. So our findings are consistent with prior studies and found that patients from socioeconomically disadvantaged backgrounds consistently experience higher rates of healthcare utilization after total joint arthroplasty as measured by hospital readmission, reoperation, and ED visitation. Charity care patients were more likely to discharge to a skilled nursing facility and experience higher odds of medical and surgical complications. Discharge disposition and length of stay are important outcomes to consider following total joint arthroplasty, as they reflect not only a patient's clinical status, but also the interplay of socioeconomic factors and access to care outside of the hospital. Given their higher odds of worse 90-day outcomes based on our study, these findings underscore the need for targeted perioperative interventions in this population. This is by specifically investigating charity care financial assistance. This study provides a more direct assessment of financial vulnerability, highlighting a socioeconomic factor that has not been thoroughly explored in relation to total joint arthroplasty outcomes. Regarding limitations, the retrospective nature of this study limits our ability to infer a causal relationship between charity care status and the variables measured. There is a possibility of recall bias of complications based on coding and documentation at the time of the initial procedures. However, these limitations do not invalidate our study, as previously studied traditional socioeconomic metrics have been shown to affect these outcomes as well. These metrics, like insurance, income quartile, ADI, can now be directly evaluated against financial assistance, which is a future direction of our research. Additionally, this study only assessed 90-day outcomes. Therefore, the long-term complications faced by these patients in the charity care cohort were not evaluated. So, traditional socioeconomic metrics may not fully capture a patient's socioeconomic vulnerability. This is the first study to evaluate institutional financial assistance on total joint arthroplasty outcomes. And finally, patients undergoing total joint arthroplasty who received financial assistance had a higher odds of readmission, emergency department visits, reoperation, and all complications within 90 days of the index procedure. Thank you for your attention and any questions or feedback that you may have.
That was a great study. Maybe 2 questions. Should the data change our indications for Anaplasty as ways for additional perioperative interventions? Suggestions on what those up?
Yeah. So for the first question, I don't think it should change what we do. These are patients that are in need, and we, in terms of changing what we do in terms of patient selection, I think the things that patients have that are going on outside of the hospital can definitely affect their, for instance, housing stability, their access to food that's healthy in their own communities, which can impact their nutrition, which we know can impact their things like prealbumin, albumin, and their overall medical status. So I think more in terms of education as well as financial support could be beneficial, but I don't think we can directly change some of those factors. I think those are things that, just to be honest, are at a higher level. We can provide things that can help supplement, but those are some larger factors that I don't think we have answers to yet. I think we're still trying to figure it out as a country, to be honest, but I think it's something that we should definitely hone in on and is important. And could you repeat your second question? Yeah, so I think appropriate patient selection and education is vital. I think ultimately these patients are high risk for some of the worst complications that you can select for. Oftentimes we'll use BMI as a cutoff at some institutions, and we last year had a great talk and have had many talks about how that may not be actually feasible, in a 1 or 2% increase in things like infection doesn't change every patient's outcome, but just a small subset sometimes. And so, although these outcomes are worse for these patients, there are certain patients that still do well. And I think it's important to look at the things that they might have had that are in those same situations to see what might actually be more of a difference than just saying they were more at risk.
Thank you.
Thank you.
It's a couple studies and those news like Ross. Common association.
Yep.
This is, I think we're using the same.
Yep.
Which I was we assume all these very very. I guess what access because visits to there, things avenues are for better cooperate us.
Yeah, so I think oftentimes these patients do, and they are pre-optimized prior to any surgery. So the more unhealthy a patient is, the chances are they are more likely to be involved with either frequent emergency department visits or have a primary care provider. I don't know the specific answer to that question, and I think it is important that you not only bring up the effect and association, but we are trying to figure out causality in some ways, and it's hard to do with this type of study. And so if we're looking at patients that are going to primary care providers for their care, it could be beneficial and helpful to kind of mitigate that. But oftentimes these patients don't have the resources to sometimes pay the copay to go see a primary care provider, and they may wait till it's too late and they have to use the ED as a potential care.
Like, right, instead of the this really awesome work for doing because so much of our research is focused on things education or decision making really has utility in advocacy and in policy making and with some research to this and something like that. I think Boone's data would be amazing to show that those patients are obviously it's mainly is myself. And I was wondering if you guys are planning down the pipeline with future residents that also do things.
I can't answer that particularly, but I think that's a great next step. I know there's a couple of residents and med students that are still involved with this project that Dr. Hernandez and the Total Joints Department will definitely keep going for this study because there's a lot of great data that still needs to be figured out in terms of associations.
I see was, but I think it's probably the shows rule of population or utilization and also I don't know that it looked like for PCP is needs that not able more of the recovery. And then there's just factors place I say about or associate but the reason riding body stuff or something else for us use rates. But yeah, we really we're starting to do so I would be great with subset. So total first is last piece with I largely all really well. There was Gallon. I'd be ready for others to work on motion like the opposite on the road. So that I only get our review is they only get 4 sessions close. Work here so we're I don't need to thank you, Arthur. I know you didn't have to about this. I was getting so else things everybody else cause
an association. But we are required by the state of Washington to report it up for his. Some of our insurers who do it. The pension is pretty good, perfect. But we've recognized that, and even a broader population, that the getting primary care in our system is really hard. Even if you're insured, there are a long ways to the system. So one of the things we've talked about for many years is having or nurse staff, which is a really cost-effective way for primary with the equation. There are some studies that demonstrate the cost effectiveness of those is working with patients post going back. So there are some ways to address refer to like as pre-op interventions to help our system to do that trying, and this data. First of all, awareness or patient intelligence, this section. Right, so this evaluation, yeah, channel. Refers us resources. Here's in response, like consensus, and pride, spirit, like here, the nation. That's it. UW medicine is heavily digital. Again, it's in this population. This is often the population access. Again, deploying more broad and maybe people on the egg. Sharon.
Thank you all.
Alrighty, we'll be taking a 15-minute break, so we'll plan to reconvene at 10. We will be taking a group photo then, so for the residents, if you can wear your white coats afterwards at 10. And then we're also going to have rows for your specific year, so if you can just sit down in your row. Cool. All right, so we'll plan to reconvene at 10. Thanks, guys.
Attention. Freddie Yang told me that we need to continue with the program so that we can all get out of here on time.
Alrighty. So next we're going to have Dr. Zach Mills, who's going to be presenting his work on total shoulder arthroplasty.
All right, thank you, everyone. I'm so happy to be here today, and thanks all of you for coming out and for your attention. I'm going to be talking today about anatomic total shoulder arthroplasty for posteriorly eccentric and concentric osteoarthritis, a comparison at minimum 5 years. Here are also all of my co-authors here, who I appreciate so very much. I have no conflicts of interest to disclose. So shoulder arthritis is arguably a big deal. Where just about 2% of people in their 40s have shoulder arthritis, the incidence rises to over 25% of folks in their 80s. With the incidence this high, it's no wonder that osteoarthritis of the shoulder is one of the primary indications for the vast majority of shoulder replacement surgeries. Meanwhile, year after year, the prevalence of people with shoulder arthroplasty has grown substantially, and surgeons report higher and higher volume of shoulder arthroplasty procedures being performed. In this context, it bears recognizing that the higher volume of a procedure that is performed, the more important it is for us as surgeons, considering healthcare value as a whole, to maximize outcomes and to minimize risk for complications. With that in mind, posterior glenoid wear is not uncommon. It is reported in approximately 20 to 60% of shoulders with osteoarthritis. This arthritic phenotype can introduce technical challenges when performing shoulder arthroplasty, whether it be glenoid exposure, preparation to it, or fixation of it.
or pose other structural challenges such as posterior instability of the native humeral head. Studies in the 2010s reported associations of posteriorly eccentric wear with frank instability, radiographic loosening, glenoid component revisions, and these findings contribute to why some surgeons choose to use implants with designs such as posteriorly augmented polyethylene components, and why others lean increasingly towards reverse shoulder arthroplasty to address problems of posterior instability and bone loss, with the incidence of reverse total shoulder arthroplasty proportional to all total shoulders continuing to rise. By contrast, other investigations reported opposing findings where posterior wear was associated with no radiographic loosening at short term, showed no difference in outcomes for glenoid retroversion, and demonstrated equivalent survival rate between concentric and eccentric wear patterns. Needless to say, this discrepancy in findings makes studying these patients a worthwhile effort. So we pose two questions. First, for patients with and without preoperative posterior wear, are patient-reported outcome scores different at 5 years? And second, does an association exist between preoperative posterior wear and radiographic glenoid loosening? This study was a retrospective review. Our institutional shoulder registry was queried for patients undergoing anatomic total shoulder. 316 patients were identified in an 8-year period. 258 of them had minimum clinical follow-up at 5 years. Patients were excluded for inadequate radiographs and alternative diagnoses. And with 210 patients included, 51 of those had minimum 5-year radiographic and clinical follow-up data. Patients included in this study underwent surgery with a standardized operative technique, which included a technique with minimal reaming of the glenoid to create a single concavity to support the glenoid component. Where appropriate, anteriorly eccentric heads were used when deemed necessary to achieve stability, and no glenoid augments were used. Along with this, patient-reported functional outcomes were documented at every time point using the simple shoulder score test scores, giving us both final SST scores as well as changes in SST scores throughout the study period. The simple shoulder test, or SST, is a scoring system that provides a practical assessment of patient's function based on 12 yes and no questions. And this is easy to administer and was used throughout the follow-up period. Dr. Yamaguchi will be going a bit more into detail on this testing score later. Beyond this, answering these questions required standardized approach to both preoperative radiographic measurements and postoperative radiographic measurements. Standard axillary radiographs were used for assessment, where the green line represents the scapular axis and the blue line represents a line normal to and bisecting the glenoid. I'll be using bold blue and red lines in the following slides to highlight each measurement that was used. Decentering, or measurement to describe the centering of the humeral head to the face of the glenoid. Humeroscapular alignment, or measurement to describe the centering of the humeral head in relation to the scapular axis. Glenoid version, or the orientation of the glenoid to the scapular axis. And Walsh classification was defined. Again, here we were particularly interested in Walsh type B1 and 2 glenoids. For postoperative imaging, in addition to repeating the prior measurements, we also included a grading of glenoid seating, which describes how well the glenoid component is supported by the bone stock, with grade A being complete seating. And we also assessed radiolucency around glenoid pegs using both the central peg osteolysis, or CPO, grading scale on the left and the Lazarus grading system on the right. These grading scales describe evidence of radiographic loosening around the glenoid component. Now, with regard to our first question, for patients with and without preoperative posterior wear, are SST scores different at 5 years? We found no statistically different significant difference in the mean SST scores after 5 years, with the average SST scores of patients with posterior wear being slightly higher at 9.6 compared to those without at 9.2. Looking at patients' changes in SST scores over the 5-year period, we found no difference in the amount of improvement in SST scores for any preoperative radiographic parameters, including decentering of the humeral head on the glenoid, the alignment of the humeral head to the scapular axis, the preoperative version of the glenoid, and when comparing SST scores between different Welch classifications. And for our second question, does the association exist between pre-op posterior wear and radiographic loosening, with loosening defined as a lucency around the central or peripheral pegs? We found that 29% or 15 of our 51 patients with radiographic follow-up had radiographically loose components, and that for those patients with and without radiographic loosening, univariate analysis demonstrated a significant difference in preoperative decentering, in postoperative version measurements, and in measurements of incomplete glenoid seating. On multivariate analysis, while none of these factors reached statistical significance to demonstrate an association, incomplete glenoid seating did demonstrate the highest odds ratio of 3.3 and approached statistical significance with a p-value of 0.082. Interestingly, a similar study to ours was published out of Washington University St. Louis in 2023, a retrospective review also, looking at posterior wear, also with midterm follow-up after anatomic total shoulder. They followed patients' clinical outcomes, including SST scores, as well as radiographic loosening outcomes, including decentering and radiographic loosening, and ultimately reported on a similar finding of an association between post-op glenoid seating and the development of postoperative radiolucency. So anatomic total shoulder arthroplasty is undoubtedly a procedure that provides improved functional outcome to patients with osteoarthritis, with preoperative SST scores being a clear indicator when compared to postoperative values. Beyond that, we found that patients with and without posterior wear had no difference in final or changes in SST scores. With similar findings to surgeons at Washington St. Louis, we identified that glenoid seating was a modifiable factor associated with radiolucency at follow-up, and that complete glenoid seating was associated with radiographically well-fixed implants at follow-up. With regard to limitations, loss to follow-up should be an important thing to consider. With lower rates of radiographic follow-up in this patient population, we feel that our study may be underpowered to find some association in the values that we were looking at. And furthermore, that there's a risk of attrition bias in that some patients may selectively drop out depending on the particular outcomes that they have. When it comes to defining posterior wear, with regard, axillary radiographs were used for radiographic measurements. 2 researchers performed those measurements, and this is subject to variation between both the researcher's technique and to the projection of plain radiographs. However, this imaging modality does have a multitude of benefits, including in particular the advantage of characterizing functional posterior decentering with the arm raised. And then finally, radiographic loosening does not define clinical loosening. And while it provides us with an observable change that would have an apparent structural association, further work would need to be done to characterize the effects of posterior wear on clinical symptoms or the consequences of implant loosening. All right, everyone, thank you very much for your attention. Thanks, my class. Any points of question or discussion?
All right.
Pain scores were looked at, but there wasn't any significant association. Yeah. No. Mm-hmm. Yeah. All right. Thanks, everyone, for your attention. All right, next we have Dr. Joey Slipka, who will be presenting on BMI and ACL tears.
Good morning, everyone. My name is Joey Slipkin. I'll be discussing my project. Body mass index and insurance type are associated with timed MRI and surgery in adolescent athletes with anterior cruciate ligament injury. I have no relevant financial disclosures. Anterior cruciate ligament injuries are among the most common knee injuries in the adolescent athlete. These injuries are often treated with ACL reconstruction. When there's a delay to ACL reconstruction, new injuries can arise, specifically medial meniscus tears. In addition, the ability to repair these secondary injuries decreases with more time between injury and surgery. Risk factors for these delays in care largely remain undetermined. Previous studies have found different demographic factors such as race, insurance, BMI, and income to be related to increased time between injury and surgery. However, none of these studies examine all these demographic factors together, controlling for confounding, nor do they focus on the pediatric population. The purpose of this study was to determine the patient demographic factors that influence timing of care in adolescent athletes with ACL tears, specifically time from injury to MRI, time from MRI to surgery, and time from injury to surgery. We hypothesized that race, insurance, and BMI would lead to delays in care in adolescents with ACL tears. The electronic medical records of all patients at a single children's hospital who underwent isolated ACL reconstruction from 2017 to 2020 were retrospectively reviewed. Inclusion criteria were patients aged 10 to 19 with demographic data available in the chart, and exclusion criteria were lack of participation in organized athletic activities, prior surgery to the ipsilateral knee, and polytraumatized patients. Demographic factors were recorded, including age, gender, race or ethnicity, body mass index, and insurance type. The primary outcome variables were time from injury to MRI, time from MRI to surgery, and time from injury to surgery. Univariate and multivariate analyses were then used to determine if any of the demographic factors above had a significant association with increased time to MRI or surgery after initial injury. Overall, 196 patients underwent primary ACL reconstruction during the study period, 42 of which were excluded, leaving a total of 154 patients in our analysis. 57% were female with a mean age of 15 years. The median time from injury to MRI was 20 days, the median time from MRI to surgery was 45 days, and the median time from injury to surgery was 74 days. With regard to time from injury to MRI, there were statistically significant relationships between insurance and timing of care in both our univariate and multivariate analyses. After controlling for confounding variables in our multivariate analysis, public insurance was associated with a 10-day delay from injury to MRI, which was significant. Continuing with time from injury to MRI, there were also statistically significant relationships between BMI and timing of care in both our univariate and multivariate analyses. And on our multivariate analysis, overweight BMI was associated with a 10-day delay from injury to MRI, and obese BMI was associated with a 26-day delay from injury to MRI, both of which were significant. With regard to time from injury to surgery, public insurance was associated with a 34-day delay from injury to MRI, which was significant in demonstrating this Cox regression. And then lastly, with time from injury to surgery, overweight BMI was associated with a 30-day delay from injury to MRI, and obese BMI was associated with a 51-day delay from injury to MRI, both of which were significant. The present study examines a wide range of demographic and socioeconomic factors associated with delays in care and focuses on two specific minority populations, body mass index and insurance type. Those with public insurance and overweight BMI had to wait on average over a month longer than their peers to get their surgeries, and those with obese BMI had their surgeries delayed by almost 2 months. On our multivariate analysis, the other factors examined, age, gender, and race, were not found to be significant when controlling for confounders. So recognizing and understanding these relationships and using it to promote healthcare equity can help us provide better care. It's terrible. Previous studies have found that race, insurance, and income to be related to increased time between injury and surgery. However, they did not account for other patient variables that could potentially confound the results, such as age and BMI. One prior study did find a correlation between increasing age and elevated BMI with increased time to MRI and surgery for patients with ACL injuries. However, this was not specific to the pediatric population. And while it may make sense for those with public insurance to experience delays to care secondary to more referrals, delays in approval, and challenges with insurance acceptance, BMI is not as intuitive. In patients with a large soft tissue envelope, either from muscle or adipose tissue, getting a reliable exam can be more difficult than with a smaller leg. Obtaining the necessary relaxation may also be more challenging in athletes with a large muscle mass. And lastly, we as providers may have a hidden bias toward patients with larger BMI, potentially misattributing knee pain after injury to their weight rather than to their injury itself. The limitations of this study include its retrospective design, limiting the ability to control for confounding factors or other variables not collected upon patient presentation. In addition, our population was not distributed normally, as there are several outliers in all cohorts. Increasing the size of our population would help mitigate this limitation, and additional studies could help determine where these outliers came from. Lastly, while demographic and socioeconomic information collected was more comprehensive than in previous studies, it was not exhaustive. Other possible confounding factors, such as parental education level and English fluency, were not examined as part of the study, but could affect the timing of receiving diagnostic imaging or surgery. Future studies may benefit from increasing even more the scope of potential risk factors for these patients and their families. So in conclusion, athletes with ACL injuries that have public insurance or higher BMI experience increased timed MRI and surgical care compared to patients with private insurance or normal BMI. Thank you.
The reason is where your patients BMI wireless to get right your ICU or patients see the outcomes of a higher BMI group compared to a lower BMI.
Yeah, for sure. So, I mean, yeah, the BMI curve, they're definitely like the obese BMI definitely had outliers, and I'm sure that could have influenced the results to your point.
You just say a few more words about the adverse effects of a delay between injury and ACL reconstruction. You mentioned the prelim new agents. Can you just say more words?
Yeah. So it's been well documented that, especially in the pediatric population, having an ACL tear for an extended period of time is not a good thing. And so these patients we try to treat sooner rather than later. Specifically, in UW has helped publish this information, but the accrual of new injuries includes medial meniscus tears, specifically as they act as the secondary restraint to anterior tibial translation, as we learned in our sports rotations. And so when people have incompetent ACLs for a longer period of time, they often have degenerative meniscus tears as a result, specifically on the medial side.
Lisa study, another question was on being biased or aggressive. Bias is really also site for biases.
Yeah, I think it's hard just because, it's hidden. So I feel like, like we all probably have some element of bias to certain like groups of patients that we aren't aware of. And so just like knowing that these exist, and when we have patients that may not fit the mold of a specific type of injury, such as like an elite athlete in an ACL tear, taking a step back and thinking like believing the patient versus believing with our like first hunch or something like that.
I believe there are within bias. There is with the bias that are
Thank you.
And next up, we have Dr. Brian Vasquez, who's going to be presenting his research on percutaneous non-union repairs. Good morning. We'll be talking about the shoulder of the pelvis. My name is Brian Vasquez. I'm a graduate of Couture resident. Next year, I'll be completing spine fellowship at UC Davis, and the year after that, Peds Ortho fellowship at CHLA. I'm grateful to my co-authors, Dr. Githens, Dr. Bray, and Dr. Novak, for their work on this project. We'll just start with the case. This is a 46-year-old female who sustained a high-energy subtrochanteric femur fracture back in 2014. It was initially treated with an intramedullary implant. At 9 months, she was remained non-united and subsequently went on to catastrophic implant failure, seen there in the bottom left. She underwent non-union repair, but at 2 years was noted to have both persistent non-union as well as a peri-implant fracture. What do we do next? This is the natural question. This is a patient who, following initial treatment, went on to non-union and then subsequently failed that non-union repair. And regarding fracture care, this is a challenging situation, and determining what to do next is challenging. Pertrochanteric non-unions are common injuries both in high-energy trauma and geriatric populations. While fixation techniques have evolved, non-union is challenging. Reoperation is associated with substantial morbidity, disability, and healthcare costs. And there's not much data to guide our decision-making in this area. So that was our goal with this study. We designed a retrospective cohort study at a single level 1 trauma center, ours, examining all patients from 2008 to 2022 who underwent surgical repair of an intertrochanteric or pertrochanteric femur fracture. We define this as 31A 1.2 through A 1.3, but this is all intertrochanteric, pertrochanteric, and subtrochanteric femur fractures. What are our endpoints? We wanted to answer 3 questions. First, what is the rate of treatment failure, which we defined as failure to achieve bony union by 1 year after revision surgery, or the need for conversion to a total hip replacement at any point due to non-union. 2, what is the effect of long-term preoperative bisphosphonate use on the likelihood of success or failure? And 3, what is the effect of medial bone loss on rates of treatment failure, and is this affected by implant choice? In terms of our inclusion criteria, we had all patients with these fracture types who were treated with revision fixation. We excluded pathologic fractures, as well as 1 patient with skeletal dysplasia. In terms of the data we collected, retrospective, cases were screened for inclusion by CPT codes for non-union repair, and all patients were followed to either radiographic union or treatment failure. We used standard statistical tests, chi-squared for categorical, t-test for continuous variables, and we use a 0.05 significance threshold. What did we find? Within our cohort, we had 73 patients that underwent non-union repair. 63 had adequate follow-up and met inclusion criteria, were included in the study. Mean age was 59, with ground level fall as the most common mechanism of injury. 88% were oligotrophic, and 8 patients had a septic non-union as confirmed by positive intraoperative cultures. With regard to our endpoints, what is the rate of treatment failure, defined as failure to achieve bony union by a year after revision surgery or the need for conversion to total hip? So in our patients with sufficient follow-up meeting inclusion criteria, the rate of treatment failure was 27%. In 6 of these cases, the patients required revision non-union repair, and 7 patients underwent arthroplasty for non-union or AVN. There was one resection arthroplasty for AVN as well. And 3 patients did not undergo further surgery due to medical comorbidities. In our study, active smokers had a much higher rate of non-union. Of the 14 patients who were active smokers, 7 of these, so 50%, ended up as non-unions compared to 20% rate in non-smokers. This was statistically significant, and smokers in our series were twice as likely to fail repair. Second, what is the effect of bisphosphonate use on the likelihood of success? 8 non-unions in the cohort presented initially as atypical femur fractures, so those associated with bisphosphonate use. Of these, 2 of 8 were treated with a cephalomedullary nail, whereas 6 of 8 were treated with an angled blade plate. 3 of these 8 atypical femur fractures went on to non-union in compared to a much lower rate of that in patients without an atypical femur fracture. All of the failures had been treated with an angled blade plate. Finally, what is the effect of medial bone loss? Medial bone loss was associated with failure in our study. Among the 14 patients with medial bone loss noted, 50% failed to heal, whereas in the patients without medial bone loss, only 20% didn't heal. This was statistically significant with a p-value of 0.02. And if the medial calcar support was missing, the failure rate more than doubled. So some closing points of discussion. So we found a 20% overall rate of failure for pertrochanteric fracture non-union repairs in our study, which is higher than failure rates reported in in other studies prior, which were closer to 10%. Our higher treatment failure rate likely reflects our large sample size and our patient population at a busy level and trauma center, where we see a lot of really challenging cases. Secondly, the time frame of our study represents an era when nails were the predominant initial implant for intertrochanteric fractures. And this is important because failure after a nail may be harder to salvage. In this 2003 study, they noted a 5% rate of failure, but most of these patients' index fixations were plates, since that was a time when nails weren't ubiquitous. And this is important because revising a failed plate, usually you have more intact bone stock than revising a failed nail with varus collapse, cut out through the femoral head, and just a more challenging situation overall. In our study, most of the patients presented with a failed nail, leaving a bone deficiency, and this made revision harder. Finally, atypical femur fractures. In our group, we had a 37.5% rate of failure in this group. Some of these were treated with another attempt at non-union repair, but others went on to arthroplasty. We think that, and part of the thought is that non-union in this group might benefit from plating in a different configuration than the original nail. This was a study that looked at a atypical configuration for treating these injuries with orthogonal plating, but lots of research still to do in this area. Some limitations, retrospective, the choice of implants initially was not randomized between a plate and a nail. There was also a lot of heterogeneity in surgical technique. This was a number of surgeons over many years. We used 1-year follow-up, but there's a chance that some of these fractures might have gone on to heal had you given them a longer period of time, and also no arthroplasty comparison. Some take-home points, these are challenging cases that require meticulous planning. We need to aim to correct deformity with good alignment and stable fixation when we can. If bone loss is present, consider axial support with an intermedullary nail rather than a blade plate, and then just set expectations with patients. Sometimes these do end up requiring multiple surgeries, and ounce of prevention and a pound of cure comes to mind. Regarding the patient we talked about at the beginning, they did go on to revision non-union repair with valgus osteotomy and blade plate, and the last x-rays we have looked good. Thanks, everybody. That got it.
I think brainless methods are always really challenging. Did you also separate these three hierarchy mechanisms? You see that data.
Yeah. Most of them were lower energy mechanisms. Most of them were ground level falls. We did not stratify out those two, but definitely I think the vascular insults at the time of the initial injury and these high energy fractures, there's probably something that changes about that environment.
And volume on that, I guess. With those.
Yeah. Yeah, one of the things that we were interested in was, the choice of, how the choice of implant, a plate or a nail affected the likelihood of success, following treatment, in these different scenarios. And, the plates and nails are pretty even, pretty nearly split between our septic non-unions. There were 9 of those. And it was just not a big enough group to really, draw an implant conclusion from that. But you could say, well, the bisphosphonate group wasn't very large either. But I think that, that small group of people with atypical femur fractures, seeing that 37, almost 40% of those went on to fail their non-union, said, well, this is something we should try to hone in on and at least direct attention for future research and future study on. But, these studies, they're small populations and hopefully rare complications.
Bit where the as well with the rashes and worse. Different treatment wine. Make sure the same way but also potentially with some lab of those position. My question for you is, do we see differences in the way they're shooting initially? Do they evolve again low numbers, but we're seeing more transitions and create referrals, shaded terrapairs, these stations?
Yeah. We didn't look too much at the teriparatide aspect. It's interesting, that's obviously coming up a lot in spine surgery as well. Patients with osteoporotic fragility fractures treated with an instrumented fusion and increasing the fusion rates in those patients after surgery. I think that a take home for me, a lot of these studies is that, there's another study we talked about Journal Club, about that, like that percutaneous, strain reduction screws we talked about at Journal Club a few months ago. I think the thought that is if you can optimize the mechanical environment for healing, that's a good situation. And I think that was our takeaway, the medial bone loss, putting you at risk for mechanical problems and too much strain to hit your fracture. And the more you can add the appropriate amount of stability, the better chance of success you have.
What do they fracture? Things always happen.
Yeah. So it was a radiographic assessment. It was subjective in that sense. Challenging to formalize. I agree, though. I think, the shoulder literature we have, we have a lot of established radiographic parameters for some of those things. Less of that exists, at this time in the fracture literature for this. But yeah. Thanks very much, everyone. All right, lastly, to round out our resident research presentations, we have Dr. John Yamaguchi, who's going to be presenting his work on Ream-and-Run arthroplasties.
Thank you very much, Freddie. Again, my name is John Yamaguchi, and I'll be presenting on the early postoperative factors associated with 2-year satisfaction after Ream-and-Run arthroplasty. I have nothing to disclose. So the treatment of bony humeral arthritis in the young active patient continues to be a challenge due to the high activity demands, lack of durable glenoid components with anatomic total shoulders, and relatively poor outcomes compared to older patients. So the Ream-and-Run arthroplasty, or hemiarthroplasty with concentric glenoid reaming, allows for unrestricted activity and avoids the risk of glenoid loosening and wear, and has been popularized here at the university with Dr. Madsen. And thankfully, we've heard a lot about this from Dr. Mills and Dr. GATTO already. From a 10-year follow-up study by Shrari and colleagues, 88% of the patients did well without revision. However, it has a longer and more arduous course with a difficult rehab process with pain and stiffness being the predominant issues. And so it can be 2 years to be similar to get similar SST scores or comfort and function compared to anatomic total shoulders. From Gilmer and colleagues, they showed that the best prognosis for patients with improvement in shoulder comfort and function after Ream-and-Run were male, older patients greater than 60 years old, had diagnosis of primary osteoarthritis and no prior surgical procedures. So we wanted to build upon these studies and focus on the 2 years postoperatively to see if there are indicators for patient satisfaction at 2 years. We noticed that these are all preoperative factors. And so do these factors also contribute to satisfaction? And part of this is counseling within that 2-year period. For example, a patient coming into clinic for routine follow-up at 3 and 6 months, are there signs or symptoms that can help guide in counseling if we should continue the course or if we should consider other interventions? So therefore, we had 2 main objectives to further evaluate these questions. First, preoperatively,
are there patient characteristics associated with Ream-and-Run satisfaction? And secondly, postoperatively, are comfort with arm at the side and ability to sleep comfortably at 3 and 6 months associated with 2 years satisfaction after Ream-and-Run? Our thought was thinking about pain and comfort as an early indicator for how the patient was doing. So we looked at 375 patients in a retrospective cohort study with primary Ream-and-Run performed from 2011 to 22. And at the 2-year time point, patients provided a satisfaction score on a 7-point Likert scale, and then were split into satisfied and dissatisfied cohorts. We collected baseline variables as well as patient-reported outcomes using the simple shoulder test as described by Dr. Mills. And we focused on the SST1, which is your shoulder comfortable with your arm at rest by your side? And SST2, does your shoulder allow you to sleep comfortably? And then we performed multivariate analyses. So looking at objective 1, patient characteristics for satisfaction at 2 years was only statistically significant for male patients. Age, diabetes, tobacco, alcohol, narcotic use, and prior shoulder surgery were not significantly different between the two groups. Now, after controlling for the baseline characteristics, patients that felt comfortable with their arm at 3 months and able to sleep comfortably at 6 months were highly associated with satisfaction at 2 years. And again, same focus again here on comfortable at the side at 3 months and able to sleep at 6 months. And we performed receiver operated curves were generated for both questions at 3 months seen in blue and 6 months seen in red. And the ability to sleep comfortably at 6 months was the best indicator with a good area under the curve of 0.76. So thinking about these patients, we found that preoperatively male sex was the predominant one that was associated with higher satisfaction postoperatively. And looking at the two SST scores with comfort at the side and ability to sleep were associated with 2-year satisfaction. Now, was this an ideal measurement of satisfaction, and what were the cutoffs that we chose? So we chose patients that gave a score of 1 to 3, which is saying that they were highly satisfied, and we're trying to maximize the number of patients that were dissatisfied to see if there were any other factors that we can find that were different between the two. However, the patients that were right in the middle at 4 was half of the patients that were included in the dissatisfied category. And what do we do with these indicators, and how do we help counsel patients? That's a significant course from 6 months to 2 years. Is this something where we counsel the patient, hey, you need to keep pushing through, keep working through it. At 2 years, you're gonna continue to feel better, or is there something else that we can intervene with? And is there a certain method that we can intervene with, which unfortunately are unsure of as of now? So similarly, retrospective design, we didn't get a chance to look at glenoid wear pattern. Was not included. It was mostly focused on patient-reported outcomes. It'd be interesting to find a difference between the different Walsh classification for these patients. And factors are used for counseling, but unclear on what / if these interventions are helpful. So the takeaways, again, we found that these factors of comfort at rest and sleep at 3 and 6 months can help counsel patients whether they continue with therapy versus intervention. Again, trying to figure out what we're going to do. So I hope this is a jumping point to continue with further research on how we can help improve these patients. Thank you. All right. Thanks, everyone. Next, I'd like to invite Dr. Sanchez-Sotelo back up here for his talk on total elbow arthroplasties.
Thank you again, and congratulations to all the graduating residents. Great research and also great presentation style. I'm very, very impressed. Thank you. So as you may know, about 80% of my practice is on shoulder, arthroplasty, cap repair, fractures, and so on. About 20% is elbow, and for elbow, I really like elbow arthroplasty. But it is a challenge because, as you probably all know, the complication rate of total elbow is very high. So infection rate, 2 to 5%, mechanical failure in younger patients, to the point that I know very famous elbow surgeons that say, I never do an elbow arthroplasty. It's just not an operation that I do. I've taken a different approach, which I think we have to try to bring elbow arthroplasty to where we are with hip and knee and shoulder, but we're still not there. But hopefully you will learn in this presentation a few things that can make elbow arthroplasty more successful. These are my disclosures, and even though my partner, Dr. Odisco, designed the latitude EB arthroplasty with a striker, I don't have any conflict of interest for this particular presentation. So there are 5 points that are important if you choose to incorporate elbow arthroplasty to your practice. One is what to do with the triceps, because triceps failure is one mode of failure of elbow arthroplasty. Second, what to do with the ulnar nerve, because even if the arthroplasty goes great, a few patients may have numbness, tingling, weakness in the hand. Third, how do you prepare your bones and place your implants, and when is it that is beneficial to link the implant? Fourth, high-quality cementing technique. And fifth, preventing the infection, because as I said, the rate is higher than in other. So for the triceps, there is basically two groups of exposures that everyone talks about when you're doing an elbow arthroplasty. Triceps O, which is to detach the triceps somehow from the proximal ulna. Classically, the Brian Murray approach, where you peel the triceps from medial to lateral of the proximal olecranon. You can come from lateral to medial and do an extensor cocker. You can divide the triceps in the middle, different approaches. And then for the triceps on, these are the approaches where you're actually going to leave the triceps attached to the ulna completely or partially. And for the triceps off exposure, something that you may not know about is a new approach that we have developed at Mayo Clinic and has become my workhorse when I want to do a high-performance elbow arthroplasty. And the keys of this exposure that we call the diamond pop-up is that we will divide the extraction mechanism in 3 steps. And very importantly, the collateral are detached on the ulnar side. And the reason for that is that the collaterals are very protected on the humeral side, but the origin on the flexor and extensor. So I'm going to play an animation that shows the exposure in steps, and then we'll go to the pictures. So first, you divide the triceps, fascia, and forearm in the shape of a diamond. And then identify what we call the main tendon of the triceps, which is actually thicker from posterior to anterior than from medial to lateral. So on the medial side of the joint is very, very thick. And then on the lateral side is very, very thin. You have to find that plane between the deeper head of the triceps, which is completely muscular at this level, and the superficial but very thick tendon of the triceps, and then place some sutures to protect it and do a horizontal tenotomy. So this is similar to doing a tenotomy of the subscapularis for a total shoulder arthroplasty. And then we're going to evert that tongue of triceps all the way distally, so it is completely out of the way. Interestingly, we have these anatomy studies that show that at least 40% of the triceps attaches to the capsule of the elbow joint. So that's actually called the triceps to capsule complex. So we divide that in a U-shaped fashion and detach the capsule from the posterior aspect of the humerus proximally. Then we're going to detach the collaterals from the ulna, and that allows to pop the elbow out of joint. Once you have the elbow exposed, with this exposure, it's very easy to size the implants. If you choose to repair the lateral head, you can do it as well. Once the implants are implanted, you're going to reverse the steps. So first we'll do dedicated transosseous repair of the collaterals to the ulna. Then we will repair that triceps to capsule complex. Then we'll use a number of crack-out stitches similar to the Achilles tendon style you guys presented today, using crack-out stitches with or without tapes, and then close that diamond fascia. And this allows to unlink the implant, and if the triceps tendon heals, typically patients do well. So step 1, cut the triceps, fascia, and forearm in a diamond fashion. Step 2, find that plane between the deeper muscular head and the superficial tendon and divide it. Step number 3, divide the triceps to capsule complex. Step number 4, detach the collaterals distally, and then you can pop the joint out and have good exposure. Alternatively, you can have the triceps on, which I love to do because then you don't worry about the triceps. And there is two ways to do it. You can either go medial and lateral to the whole triceps. That's called the Alonso Llames approach. It was described in my hospital from Spain in 1963. And this was used mostly for distal humerus osteotomies back in the time. But this is the approach that Dr. Bernie Murray adopted when he did total elbow for fractures. So when you do a total elbow for fracture in a very old patient, you can actually remove the pieces that are fractured, and with the triceps on, you have a nice window to work because the bone has been removed. Then you can instrument the canals and cement the implants. Dr. Graham King from London, Ontario, has developed this so-called lateral paraolecranon, which is brilliant. So it's not triceps split, it's a split slightly lateral to the portion of the triceps that attaches to the olecranon. And this is great in patients where you're doing a revision total elbow and the distal humerus is more intact than when you do a triceps detachment, the way that Alonso Llames described it. So I think that the contemporary elbow surgeon that does arthroplasty should use both exposures. The benefits of a diamond pop-off or triceps off is way easier to look at the bones and the implants. You can leave the ulnar nerve in situ. It is more stable if you do unlinked, and the skin flaps are smaller. So those are benefits. But if the patient gets infected, the tendon may not heal, or if they have an injury, and you have to tell the patient you cannot use your elbow against resistance for several weeks so that it doesn't fail. The benefits of a triceps on is that you have no failures because you never took a triceps off. And then the patient doesn't need to get any protection, right? Because once the implants are cemented, if the skin is healed, they can do whatever they want. But there is no question it is more difficult to get the implants perfect with the triceps partly in their way. The ulnar nerve has to be transposed. And if you do an unlinked arthroplasty with a paraolecranon, it is more unstable. So I use a diamond pop-off in the high-performance implant, a patient that is younger, that I can do an unlinked prosthesis, and I want to use a short stem. I'm going to replace the radial head. I will use a triceps on for fractures, revision, or patients that need upper extremity weight bearing. So that's point number one, triceps. Point number two, the ulnar nerve. And this is always controversial, paraphrasing Hamlet, to do, what to do with the nerve. That's the question. In trauma, there is a great study by the Canadian Orthopedic Trauma Society that showed that it doesn't really matter if you transpose the nerve or not. For distal humeral fracture fixation, the final rate of ulnar neuropathy is the same. In arthroplasty, I believe that the rate is underreported. At least my rate is more than 2%. I think that most of us don't document in the clinical notes adequately the ulnar nerve function. We're just happy the patient wasn't infected, moves the elbow, has no pain, but I think it's actually higher. But in general, I think it's linked to the implant. So what I typically do is leave the nerve in situ if I do a diamond pop-off, and then mobilize it completely if I do a triceps off approach, a triceps on approach, sorry. In terms of bone preparation and linking, these are the four things to take into account. One is that for an elbow arthroplasty with contemporary implants to be successful in terms of longevity, we need lateral column load sharing. So you want the radial head to be articulating with the distal humerus, either the native radial head, as you can see on the image on your right, or the replaced radial head if possible. And this is challenging because when we're doing the operation, we get the impression that the ulnar component has to be in the dead center of the face of the coronary fossa, and that is not it. You have to actually go more lateral, as you can see here. So in this particular patient, the ulnar component has been already cemented, slightly medial, and then you cannot really get the lateral aspect of the component to articulate properly unless you use a bigger size. So you have to place your ulnar component slightly closer to the radius than you think if you're going to do lateral column load sharing. Rotation is very important because if the implant is unlinked and mal-rotated, it will dislocate. If the implant is linked and mal-rotated, it will wear out the polyethylene. On the ulnar side, the best reference is the equator of the radius. So if you trace a line with a marking plane in the radius and rotate the component on the ulna so that the equator of your component is parallel to that line, you're going to be fine. But sometimes patients come to you with no radial head. So then that's missing. There's a study that Dr. King did showing that the posterior aspect of the olecranon is also parallel to the flexion-extension axis of the elbow. So you have two parameters. If you have a radial head, great, you can use that equator. If you don't, you can place your component parallel to the back of the ulna, you're going to be okay. The humerus is different. The humerus is actually internally rotated in reference to the posterior cortical line. When I was a fellow, I was trained to place a component parallel to the posterior cortical line in patients that had no bone loss, where you have no epicondyles and you don't know where you are. But these studies that have been done that show that the transepicondylar axis is rotated internally 10 to 15 degrees in reference to the posterior aspect of the shaft, which is what you can see. So when you're in the OR looking from the top, remember to place a component in internal rotation, more in females than in males, between 10 and 15 degrees. That will help you with the rotation. Depth of insertion is very important if you do a linked prosthesis, because when the implant is linked, if there is impingement in the front, as the patient flexes the elbow, it's going to lever out both components that are linked. And typically the ulnar component, as you can see in the illustration, can become loose if you have a linked implant and you don't clear any anterior cement osteophytes that may collide with the flange of the humeral component of the distal humerus. And finally, linking, we believe that if we want a longer lasting implant, it's probably better to leave them unlinked, but you can only do that if you have a good triceps, the collaterals are intact, and you can reestablish lateral column load sharing. So in those patients, I will do a diamond pop-up with a short stem unlinked with a radial shed. However, if the patient has a compromised triceps, no ligaments, no columns, then you have to do a linked implant, which works reasonably well. And then moving on to the cement, this is very important too. In the lower extremity, when I was a fellow, I was trained that you wanted to have 1 to 2 centimeters of cement below the tip of the femoral component, because that was considered a good cementing technique, not a good idea at the elbow. The elbow is not a load-bearing joint, and you don't need cement past the stem. And that's very important if you do revision surgery, because what you don't want to do is to remove the component and have to dig out another 2 centimeters of cement. So as you can see, I place my restrictor flush with the tip of a prosthesis so that no cement goes beyond the tip. In case this fails, it will really help us. And I always add vancomycin and methylene blue to the cement. Then the cement is colored in blue. And if you have a patient with an infection, you can identify very, very clearly. So here you can see how we're trying to determine that the depth of insertion of the restrictor is just collinear with the tip of the stem. And here, how you can see how the cement is being inserted with a flexible, elbow-dedicated nozzle with vancomycin and methylene blue inside to recognize it. And then infection is a big deal. So since elbow arthroplasty most of the time, other than fracture, is elective, I will cancel this operation to patients if I have any concerns. And it's very important to be pretty thorough preoperatively. So for me, if a patient is smoking, it's a no-go. The patient does not get an elbow arthroplasty unless I can prove that there is no nicotine use at all. If they have diabetes, I want to see a reasonable hemoglobin A1C. And if they have any question about nutrition, I'm going to get albumin levels as well. And I will get the patient to get protein shakes and other things before we do the operation. In patients with rheumatoid arthritis, you have to ask about what type of DMARD are they using. I always check for possible occult UTIs in females mostly and dental health. And if a patient had any possible infection, I will either aspirate the elbow or more commonly do open biopsies. So a patient comes to me, had a distal humeral fracture that was open, had plate fixation that failed twice. The patient was placed on antibiotics. I'm really worried. So in that patient, I'm going to do a very small triceps split and take biopsies. It's very no morbidity there, just to make sure that there is no infection before I commit to the arthroplasty. In the operating room, I really like to cover the arm with ioband and place the sterile over the ioband. That's not classic teaching. Classic teaching was to place the tourniquet underneath the drapes. And then what happens is that as you're trying to get your exposure proximally, it's very easy to contaminate the surgical field. So I like to isolate the whole field, then place the tourniquet. Second benefit is that if you go over in time, you can very easily remove it. And I have fallen into the bandwagon of using vancomycin powder at the end of the operation, which I think is very controversial. We don't have any data, but I do it because I do everything possible to prevent infection and also know when to bail out. If you are already committed to an elbow arthroplasty, you expose the elbow and there is any concerns, it's better to close it up, take cultures, and come back 2 weeks later, as opposed to placing an implant in a field that can get infected, because we are very poor about curing infection after elbow replacement. And then after surgery, I have migrated using a vacuum-assisted closure device in all my orthoplasties for 7 days. I don't have any conflict of interest, but I use Previna for 7 days. And the elbow is splinted in extension. And the reason for that is that when the elbow is flexed, the skin is under tension. So you want to have the elbow extended and high in the air. If you have any question in your mind about broken infection, I will get them on oral antidote for 2 weeks. And then if the patient in 2-3 weeks have concerning findings in the wound, I have a low threshold to go back to the OR and do an IND and a primary closure. But when you're careful with doing all these things, patients can do extremely well. So this is a classic example of a patient that is in his late 60s, so not super old, but not super young either, already had arthroscopic surgery that failed, and you can see how he has some limitation on range of motion, but more importantly, a combination of mid-arc pain and impingement pain. So sometimes in elbow OA, it's difficult to tell if the joint hurts. This is one way to do it, which is to ask the patient to move the elbow in the mid-arc in flexion extension against resistance, and if that hurts, then that tells you that the patient has mid-arc pain that comes from the joint, and also, of course, impingement pain. So in this patient that had intact columns, great ligaments, and I'm looking for a high-performance implant, today I will try to do a diamond pop-up with a short ulnar component and link and a radial head with adequate alignment in rotation and translation, so we have lateral column load shedding. And those patients are doing very well, and they come to see us and they kind of forget they had the elbow replaced. So I think there is hope in the future where, following these steps, hopefully one day we can trust that elbow arthroplasty is equivalent to hip and knee or shoulder. Thank you very much. Any questions about total elbow arthroplasty? I know it's uncommon in many institutions.
Yeah, maybe what are not involved in making papers the better stability so we can play this compared to a lot or left non releasing the lateral up or the shear side.
Yeah, so what happens when the elbow moves, if you think about my shoulders being the lateral and medial epicondyles, and my hands are holding the ulna, when the elbow goes into flexion and extension, if you look at my hand, they are not moving. My shoulders are. So with flexion and extension, the distal aspect of the ligaments remains almost under no shear, whereas the proximal aspect is under constant shear. But I think if you detach the ligaments from the humerus, they are more compromised in their healing potential because they have more shear. Secondly, to have the overlying flexor and extensor groups further protects the ligaments that are underneath. But I think detaching the ligaments from the ulna is very protective for the ligament integrity. That's why I think the diamond pop-up is more stable, provided your triceps heals, because the triceps is very important for implant stability. So if the triceps doesn't heal, the patient may still dislocate posterior because there is no triceps to support the elbow.
Just could you comment a little bit how you repair the ligament when you do that diamond pop-up?
Yep. So typically what I will do is get a 2.0 drill bit and create a drill hole in the ulna on either side. And then I pass a typically number 2 fiberwire suture through the ligament distal end and into the bone. And then oftentimes this implant has also a channel in the humerus where you can pass a suture through. So I pass a suture that goes through the implant and through those same holes so that the suture will keep the elbow opposed until it finally breaks and keeps the ligaments attached. So it's a dedicated transversus repair before cementation.
So you get to the years that video coming on with approach. Or the dogs, well, approach for an art, which challenge the stuff. You guys still have been able to create approaches.
Yeah, so this approach was a combined effort of Mark Morris, who's my partner, Shannon Driscoll, and myself. The first step came up after we did a study on the anatomy of the distal triceps insertion for triceps tears. And then we realized how that tendon of the tricep was so different that we thought in our minds. Then we looked at MRIs and decided, to really understand the morphology. Then we went to the cadaver lab together and did a number of studies on just the anatomy, understanding the three of us, how we could get to the elbow. And then we did one study that is to be published in cadavers that were looking similar to the Achilles tendon study, yes, please, to look at potential strength of the repair, and then went into patients. And I think, to your point, if any of you become a common elbow arthroplasty surgeon, I think it's wise to watch someone do the video and then do it in a cadaver once or twice. It's not difficult, it's just tedious, and it requires to be meticulous. So I think people that are hand and elbow surgeons actually do a better job because they are more delicate. The shoulder elbow surgeons are less delicate. Sometimes we want to skip through steps, but if you are a delicate surgeon, you can get it done very well. And it's very pleasing in terms of the exposure. I mean, you have the elbow wide exposed to you, whereas with the triceps on, you have to turn the forearm and get an angle, and sometimes it's difficult to get the implant where you want, especially in rotation.
With the analysis and you're getting a year, how you're.
Those are great questions. So one challenge when you look at the literature on total elbow arthroplasty is that it is dominated by the Humeral implant, which back in the days was a breakthrough. So Dr. Moore was a genius, because if you go back to the 70s, all the other implants were disasters, right? But that implant had 2 or 3 things that people don't know about. One is that the coating of the implant changed over time. So until 1993, they had a very poor quality plasma spray. Then William Harris in the hip world influenced to use pre-coated implants in the hip. There was a thing called the central line implant. And then the Conrad Mori adopted that from 1993 to 1999. That had a terrible failure rate. And then in 2000, they went back to a higher quality plasma spray. But in the studies, they are all lumped together. When you look at a study that reports from 1984 to 2022, you will see all 3 implants. Also, there was a time where the axis pin was made of titanium, and we know that titanium on Pulley is no good. Now it's cobalt and chrome. And also, the mechanism itself was like a little circle on one of the ends that was poor. So it's difficult to isolate the outcome of those patients. But if you look at the patients that had the Conrad Murray after 2000, humeral loosening was never a major problem. It's polyethylene wear. And this is polyethylene that is not vitamin E, not cross-linked, sterilized in air, right? So that kind of explains that. With the newer implants, and again, I have no conflict of interest, the geometry is better. The quality of the poly is still not great because companies that make these implants don't make a lot of money. They have 0 interest in getting vitamin E into an elbow arthroplasty. So that's everywhere in the shoulder now, not in the elbow. Having said that, with the better geometry and understanding the lateral column lobe sharing and everything else, I do have changed my indications, and I offer it more freely to patients that in many other places they are told you should never have an elbow arthroplasty. So for example, I had a patient recently who is 44. He's from the UK, but he lives in the United States now, and he had a distal humerus fracture that went south, multiple surgeries. He had no distal humerus. He's miserable. So I did a total elbow, but he's 44. So I know that I'm getting potentially in trouble, but the guy has no other solution. So I think in those situations, I do it. In terms of restrictions, it's very interesting. So my mentor, Dr. Bernie Morey, told me that the rule that he wrote in every book about you should never ever lift more than 1 or 2 pounds, except maybe once a day 10 pounds, came out of the blue. He just made it up. He just wanted to tell patients something, so it's not based on any mechanical analysis of how much the poly can take, And I think it's better to explain patients what is safe and unsafe. So the case of death of polyethylene is cyclic loading. So I tell my patients, if you're going to use your arms for weights, but you keep your elbows locked, you're probably okay. So I tell them, if you have a suitcase in the floor and you have your elbow replaced and you bend your knees and grab the suitcase and walk with it, probably nothing really has happened. But if you want to go to the gym and pump iron and, work on your biceps, that's not a good idea. So I tell them not to do weight training, but I tell them if you are going to take a flight and you have to lift your suitcase once a day, that's perfectly fine. And that completely changes the dynamics because in their mind, they've been told you can never lift more than 1 pound. Well, almost everything is a pound, so it's impossible to lift. To further complicate that, we did a study that my partner John Barlow was the lead author. We have a survey research center where we can send surveys to patients. So we identify patients that had an arthroplasty implanted, and we ask him to check yes or no if they did some activities that we classified into high risk, moderate, or medium. And 94% of the patients did something that we know is a no-go. For example, in Minnesota, where there is snow, patients were shoveling the snow because they have to. Because if it snows a lot and you're at home alone, what are you going to do? You need to go to the grocery store. Or, the pellets for a water softener, those are very heavy. But if an elderly patient lives alone, he or she has no choice. And we ask at the end of the survey, do you remember that your surgeon told you not to lift? And everyone said, yes, I remember. But I have to leave, right? So I think it's unrealistic to offer these patients this operation and tell them you can never lift more than 1 pound. I just explain to them how they should handle the elbow and make them aware that if they overdo it, they will pay the price. So it's partly the responsibility. I don't know who wants to go next.
In terms of the I'm always being younger in my career, worried about the next surgery. And then revive or go back in and just doing or on.
Yeah, so I have had myself one failure of the tenotomy in a lady that has juvenile rheumatoid arthritis. I replaced both elbows. In one side it healed perfectly, in the second it didn't. So I had to go back in and do a repair and then overlay an Achilles allograft for augmentation. And I know that Sean had a couple of patients that became infected and then the triceps tendon doesn't heal. So there is no question there is some risk of tendon not healing. You have to tell the patient about that, but it's not very common. I have also gone back in 2 patients of Driscoll that they had ulnar neuropathy after surgery. So I did the force to transport the nerve and the triceps looked pristine. So I know that in some patients it does heal. I've seen it with my eyes, but it's not very common. We haven't had many failures, but they can occur. And you have to protect the elbow for 6 weeks. Jonah?
First of all, Mayo, very different. There's volume. Corrected. Most likely in the problem is then they go and no one wants to their ag shoulder. I think there's a burning. Like in their clinical number, then how do they work when they go to that one? The same should be one person.
That's such a great question, and it's so difficult to answer. For example, in Central Europe, they have decided in some countries to centralize total elbow care. So the UK is about to approve basically a law where total elbows are only done in 3 or 4 centers of excellence. I don't think that will ever happen in North America because the culture of the patients and the surgeons is different. So I think for the residents that are going to now do a shoulder and elbow fellowship, when you take your job, you're going to be considered the elbow person. Same thing for hand surgeons, that do fellowship in hand. I think there's one person doing hand and upper extremity, right? As you. So for Gabrielle, it's going to be the same situation. So I think it's important to get yourself trained. And I don't know that we know what is the minimum amount of cases that you have to do. I don't know for sure, but I'm sure there is a learning curve. I just don't know how we can solve that from a society perspective. Ideally, I think that total elbow for acute distal humeral fracture should be learned by almost everyone that has an elbow experience, because for a patient who is frail, like 85, fell and fractured the elbow, it's very impractical if that patient lives in Seattle to go to Mayo Clinic. If you're 45, it's different. For the younger patients that have an elective indication, it would be ideal to have a few centers of excellence. But I think for the younger people, when they join the practice, no one wants to do elbow. You're going to get inundated with patients that have disaster elbows. The question then is what?
Unlinking prosthesis. What's your advice to people who are thinking, they think, oh, I've got a perfect patient, I'm thinking about an unlinked prosthesis. What's your thought process?
Yeah, so I try to push for an unlinked implant in a patient where I want longevity. And we don't know for sure if that's going to pan out, is the whole. So good collaterals, good lateral columns. I will do a diamond pop-up. I want a radial head to humerus contact as well. If I can do all those criteria, I will plan to do it unlinked. But sometimes I have found myself that I fracture a column in drop and then I end up linking that patient. So I think that you should only push that indication for the patient that has an otherwise perfect elbow in terms of columns and ligaments, and you're trying to give that patient a very, very long-lasting implant. Probably most surgeons are safer doing a linked implant. The benefit of the latitude, and again, I have no conflict of interest, is that if the patient becomes unstable, you can do a very small triceps split, place the cap, and it's linked. So the revision for instability is actually very simple, so that makes me more prone to think if I'm on the edge, I'm going to do it unlinked, hope that everything works, but I tell the patient there's as much as we may need to place a cap in a second operation in the future. And I don't do it for fractures, of course, because the columns are going to be excised. There's no collateral. So I think for most surgeons around the world, a linked implant is safer. But if you have a 44-year-old that has a destroyed elbow and there is any way you can leave it unlinked, the hope is that it's going to last longer. But we don't know.
What do you think about the idea of linking it in this? Back and not linking it.
It's a great thought. The question is, if you have a well-functioning linked implant, is the patient going to accept to go back to the OR again to take the link out, hoping that the longevity is more? I think the acceptance by the patient, it's a great idea. That's the idea of the suture. Keep it together until finally everything heals, so it would be even better to do with the link and then remove it. Or if they had like an absorbable mechanism that you can fit in the ulna or something like that. But the problem is that there is no money in the elbow, so companies are not going to invest in sophisticated solutions. Jason?
Sequence involved unrigged in places, everyday tasks are going to be tricky. The last thing where you replacing a radial head and when you do it, because you were talking about the fix and a whatever here's or humeral.
Yes. So very good question. So for the first question, if a patient has an intact radial head, I do not replace it. So if it's not arthritic and it's intact, then I just basically use the patient's native radial head against capitellum, and I haven't seen major pain because of the radial head being now cartilage against metal. If a patient has a resected radial head or a very arthritic and deformed radial head, then I replace it. And this goes more into implant design, but the first generation radial head implant of this implant was a disaster. So it became disassembled all the time, and the stem had no coating, so it became loose. So I never used the first generation radial head implant because I knew it was not working very well. The new one that came out about 2 years ago has better coating and a better mechanism of bipolar, so now I trust it more, and I haven't had any failures of that implant. In terms of the lateral column lobe sharing, the key is to make sure that you have the sizing right. So there is in the system a small, medium, large, and large plus. So with that, you can cover almost the whole spectrum of human sizes, but you must translate the ulnar component laterally. So in the OR, when you're looking at the face of the ulna, you get the burr and you want to be in the center. And if you do that, the ulnar component is translated slightly medially and then it just doesn't articulate. So I almost always find myself using a burr and translating my ulnar component laterally, and then it tracks. I use the trial like I showed in that example to confirm I have good tracking.
All of versus and university.
I size the elbow by using the sizing spool on the forearm, and I do the forearm first. So I do radial head and ulna first. And I get the implant trial of the humerus and see if I am within the ballpark. Then I do the humerus. That's my sequence. Jonah?
Really? It is part of elevate. But short stem, the base set like that, and then it sort of lasts probably to the late as
Yep.
Illegal that at least. It's like I didn't see my year belt and procedures, right?
Yeah. I think it's more patient acceptance, like you said, and that's what Dr. David said is important. When I link the implant, I use the second length stem. If I do a link, is when I use the ultra short one. Hopefully that if I had to revise it, is, as you can see, there is less invasion of the canal distally, so it's pretty easier to revise. Well, thank you for your interest in the elbow. That's nice to see. Thank you.
All right. Thank you to all chief residents for presenting your research, as well as to Dr. Sanchez-Sotelo for coming down here and giving us 2 great talks. We will be having our festivities at the Columbia Tower Club, and we'll start at 6. So I look forward to seeing everybody there tonight. All right. Thanks, everyone.